I was to speak on coagulation blues, but my very dear friend who is more expert on this, Dr. Kausal Sheth, will be giving a complete enlightenment on that. So I thought let me as well change the topic, because this is this was something new for me. It is old, but it was new for me. So I thought let me just start with it. Well, friends, whatever I have written is straight from my heart. Around 40% of the patient with septum deviation, which was mild or moderate, and who had allergic rhinitis. The common practice was initially give them cetirizine, all the baki jo bhi modalities kare, and then ultimately convince him for a surgery. Once the surgery is done, then almost out of the surgery is done, 40% would come back, sir, zukam to kam hua hi nahi hai. The running nose, the blocked nose, the redness of the eyes, the irritation in the soft palate, nothing is gone. What to do? So then the answer was, kuch bhi bahana. It is your bad luck. Kuch nahi kar sakte. Wo tumhara taasir hai. We cannot change the whole thing. Whatever is there, your nasal obstruction is gone. You know, we have got so many pretexts to say, and we find out all these pretexts and ultimately come back to whatever we have done is correct. But I was not personally happy from inside, because, friends, wherever I belong to, my area is a complete ocean area. So the allergic rhinitis and allergic polyposis is very, very frequent over there. And in there, if you keep on convincing, from within my heart, I was not happy that whatever is happening, I am not happy. Continue him on fexofenadine medicines, and then nasal corticosteroid sprays, and then azelastine, and whatever, keep on doing something new, but I was not happy. Whenever since I was introduced as a past National AOI President, since last 10 years, all these conferences which I was attending, at that time, of course, in a small part, but then later on a bigger part, allergic rhinitis, its management and immunotherapy was always a topic in some of the other conferences. But I was not mentally convinced. I thought, yeah, this is also one of the gimmicks. कि भाई चलो उसको ये नहीं है तो उस पर चढ़ा दो, and nothing will happen, कुछ ना कुछ, ताकि वो चलता रहे. But with passage of time, I started believing, because after attending lectures and seeing the results that the people who are doing immunotherapy and allergic tests, I started believing into it, into the skin prick test and the immunotherapy. Because then I started finding a ray of hope in my patients, कि अगर इसको मैंने कुछ भी किया है, so in some patients who have got a slight deviation of nasal septum and a classical allergic rhinitis, should I go in for surgery? Because with surgery, I am going to get more money, no doubt about it. But at the end of the day, am I going to treat him nicely? Maybe not. So then this was the question which I was asking to me, and I got an answer in this. So what I did was, I organized a hands-on workshop to know the basics and did hands-on skin prick test. We had organized this workshop in Udaipur, and we had called Dr. Sunita Chapola Shukla, and exactly what it is. So we had a one full day workshop with all the lectures, how to get the allergens, from where to get the allergens, how does the immunotherapy help, what are the things in which we can try doing skin prick tests. Recurrences of polyps, chronic sinusitis, bronchial asthma, nasal allergies, failed surgeries with nasal allergy, allergic rhinitis. Not only that, irritable bowel syndrome, many, many things are there, skin allergies associated with normal allergies. So she really teached us that these are the vistas where you can start doing it. So what I learned was, I learned that there are definitely different types of allergens. We have been hearing it, but then we really do not know. But when I started putting into practice, there are dust and mites, there are pollens, there are fungi, there are insects. Food definitely has an allergy, fabric and feathers. Because many times what happens is, we just ask, क्या लगता है? Sir, मेरे को ये खाने से allergy है, avoid करो. Sir, whenever I get a smell of or a fragrance of a perfume, I get running nose. Sir, after I come out of my bath, I am getting running nose. Sir, after doing this, I am having this. या किसी को वो वैसे dusting किया, running nose. But then, when I found out dust and mites, in dust and mites there are almost 21 allergens which you are supposed to test. वो तो पता ही नहीं था. I was really not knowing कि इतने से इसकी किसी की भी एलर्जी हो सकती है. So, and then they definitely have a role in allergic rhinitis. The symptoms, what I told you, was running nose, blocked nose, heavy sneezing, postnasal drip, asthma, etc. So, how to establish an allergy clinic? We want to establish an allergy clinic. चलो, we want to start. हमने समझ लिया कि क्या करना है, क्या नहीं करना है. We understood that there are allergens which are there. We need to get the allergens, from where to get the allergens also. We have people who can send you the allergens. What to do? How to establish a skin prick clinic? I was always in a dilemma कि क्या करना होगा, क्या नहीं करना होगा. Is it time consuming? What will happen? How much time will I have to give to the patient? Because naturally we feel कि इतना time 15, 20, 25 मिनट दे रहे हैं तो उसमें तो surgery खत्म हो जाती है. So it's always better to do a surgery rather than to do all these things. But then ultimately it is very, very easy. The persons who are with the allergic, who are giving you the allergens, they can do the allergic mapping of your area. Like my area, the coconut is growing over there. So whatever the pollens are there, and they come out from the coconut, those pollens are found out. And they will send you those type of vaccines so that you can take the allergy from that. Even the cow dungs. Shepherds are too much on our side. So the cow dungs, the new generation is very, very fast in pizzas and burgers and everything. So the yeast, the bread yeast, the chapatis, the wheat, garlic, all those things they find out, and then they give you the allergens. So learn skin prick test, which is very easy. First thing is take detailed history, कि उसको किस वजह से हो रहा है. You should have a good illuminated room so that you can do a nice skin prick test. Comfortable table on which the patient can rest with their hands properly. A lamp, nice lamp, illuminated lamp to observe the allergic flare in the wheel. Emergency medicines. Suppose if the patient gets some reaction, keep adrenaline and Dexona so that SOS can be given to them. Up till now, at least I have managed only 18 patients. And kuch nahi hua hai. It is very easy, and now gradually I am teaching my staff to do it. It's that easy a job to do. So there is no question about it. First thing is stop antihistaminics, steroids and drops 5 to 7 days prior to the test. Investigations, yes, IgE has to be done, but usually IgE is always high and it is basically no role. So I avoid doing the investigations in that. Explain the patient about the procedure as to what we are going to do, because many times this is a new thing to happen. So explain the procedures. First thing is that you do a histamine prick test. Now, where exactly it is to be done? It is to be done in the forearm. Just put 2 fingers away from the cubital fossa and 2 fingers away from the wrist. The remaining area is all yours. Just first mark the histamine circle and make it with H. Second is saline, which is control. And put a drop over there, and there is a small, either you can use a lancet or you can use a small needle, and then with that just lift the skin. There is not even a blood spot and it is almost painless. Just slightly lift it and leave it. Let it remain for 5-10 minutes, the wheal will start appearing. Once it starts appearing, then what you can do is you can mark whatever allergens you have found out. You can just mark those allergens on the hand and start doing the test. Once you do the test, so make wheels of selected allergens on the forearm, put drops of the allergens on the marked circle and just lift the skin with either lancet or needle. It is absolutely painless. It happens within 5 to 7 minutes. Just slightly prick, slightly lift it, and tuck, 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 tuck. Many times you will feel lift hua ki nahi, but you can see the skin being lifted. Slight lift and chhod do, slight lift and chhod do. That drop goes in, and definitely you will get the results. This is one of my patients. So wait for 20 minutes. Compare the flare and the wheal formation with the histamine flare and the wheal, and I have made a chart of what are the allergens, I am going to check, and how many millimeters I am going to get the wheal and the flare. So once I get the wheal and the flare, I send this report and get my immunotherapy. Now, many times we have our questions that how will this immunotherapy work, and initially immunotherapy the pediatricians used to give, and it was subcutaneous injections and all those things which we used to hear, and we used to say अरे उसका कुछ नहीं है वो करते हैं लेकिन कोई फ़ायदा नहीं मिलता है. But yes, it definitely works, because we all have been residents in our first years. When we joined our residency, we were very fagged out, very tired. As the time went on, we started getting adjusted to ourselves. In second year, we were almost accustomed to the department. Third year, we felt like this is my department and I should do something for the department. In the fourth year, everything was perfect and we are on the dot with the department. Maybe we would like to proceed with the department. So same thing is happening over here. Whenever we get an allergen, the body responds with histamine and we get all these symptoms. We all know very well. But what happens is that if you give them in low doses, in 1 drop, 2 drop, 3 drop, 4 drop, 5 drops, and then continue with them, the body starts getting accustomed. अरे ये तो ठीक है, अरे ये तो ठीक है, ये तो ठीक है, and start forming antibodies against this. So whenever in future the body is exposed to these antigens, the body will not respond by releasing histamines, and the patient will be off his symptoms. This is a simple gimmick of the whole thing, and it's very easy. Whenever the immunotherapy comes, it comes in 3 bottles. Ideally, there are 2 ways of doing it. Either you can sublingual immunotherapy or subcutaneous immunotherapy. Initially, subcutaneous was going on, but patients has to get a prick over there. Here, you are given, you will be sent 3 bottles of immunotherapies. 1 bottle, you have to continue 6 drops for 20 days, and that bottle gets over. Simultaneously, the another bottle starts wherein the 6 drops per day, which will go for 1.5 months. And the last bottle is 6 drops per day, which will go for 6 months. So then you ask the patient to come back on a regular follow-up and see his results. Friends, I'll tell you one thing. 16 patients are with 6 months follow-up with me, 3 months or 4 months follow-up with me. Immunotherapy since 3 months. And patients are happy. Because what happened was, I had organized this workshop somewhere in July, August. Immediately I started. Now that season is a changing season. The rains did not recede and the winter slowly came in. In between there was warmth also. The October, September heat also was there. So there is one of the very season where there is lot of allergic things happening. And my patients who are on this, they said, sir, utna episode nahi aata hai. I had told them, whenever you get episodes, you can take levocetirizine, you can put a nasal spray, there is no problem. Just support yourself, don't unnecessarily suffer. And gradually these things started happening, and my patients are really happy with this. Counseling of the patient is very important. Immunotherapy will last for almost 3 years. During or in between episodes, patient can take antihistaminics or nasal spray, and regular follow-up is very much required. Why allergy clinic? It's the need of the hour. It is cost effective, it is easy, and it is result oriented. We have with us Dr. Vikram Khanna, who is expert in doing all these things. And in fact, my tryst with allergic rhinitis started when I met him in Udaipur. And when he enlightened me on this, the whole thing, and he has a lecture following this. Vikram, I am a teetotaler and a chlorer as far as allergic rhinitis is concerned. So kindly correct me wherever I am wrong. But this is just an overview to make people aware that yes, allergic rhinitis works, it has a cure, and immunotherapy definitely has a role to play. Thank you very much, and I really thank Sudhakar sir. I am very thankful to the entire organizing team to allow me to present my topic. And in person, let me thank you from this platform. I would like to thank, special thank to Dr. S.P. Dubey sir and Dr. Sanjay Agarwal sir for making me, Dr. Medikere sir and Kaushal to do the Bhasma Aarti today morning. Thank you so much. I am really indebted. Thank you very much. Sir, we are not allowing questions because the reason is, sir, we are slightly delaying in time.
Okay.
So if anybody has something to ask, of course, Vikram is the best person to answer these questions. If anything is that, after that I can answer. Small questions will be answered by me, long questions will be answered by him.
Okay.
Sir, Vikram is there, but sir, let us answer because we have Dr. Jankiram's lecture to follow over this. His oration is there. So we'll answer I will answer together in dinner time, sir.
Thank you, sir, for enlightening us all on this amazing topic. It was a delight to hear from you. Moving ahead, I would like to end this session with felicitation of our moderators. I would request Dr. Sudhakar Vaid, sir, to please felicitate Dr. Viral Chaya, sir. Now I would request Dr. Sanjay Agarwal, sir, to facilitate Dr. J.K. Sharma, sir. Now I would request Dr. Kaushal Seth, sir, to felicitate Dr. Tej Singh. Now I would request Dr. P.N. Verma, sir, to felicitate Dr. Puneet Bhargav, sir.
Now coming on to the next session, which is Padma Bhushan Professor L.H. Hiranandani oration. And for that, we'll be talking about GNA tips and tricks. So first of all, I'll be calling the chairpersons for this session, respected Dr. S.B. Ogale, Dr. Sanjay Agarwal, and Dr. Sudhakar Vaid. I would request them to please take their seats on the dais. And for this oration, we'll be calling upon none other than Dr. T.N. Janki Ram, sir, who indeed needs no introduction. So I humbly request Dr. Janki Ram to please come forward on the stage and do the oration. Sir.
Good afternoon to everyone. I welcome you all to Padma Bhushan Dr. L.H. Hiranandani oration of AOI National Midterm Conference. As you know, Dr. L.H. Hiranandani was a founder member of AOI and chairman of AOI Research Education Foundation Trust. He was the person who brought our association on global map, particularly in field of head and neck cancer surgery. In year 1985, he along with Dr. Prem Kakkar, Dr. P.P. Karnik, Dr. K.L. Shah, Dr. Pusalkar and Dr. Ingre founded AOI REF, registered by Charity Commissioner, to accelerate the academic activities in ENT field This includes seminars, conferences, workshops, research work, and travel fellowships. Also to organize operative and diagnostic camps in rural and remote places. AOI RAF is giving grant for CME program during AOI conference every year. AOI RAF is also funding for mid-term conference held by AOI branches at different places. With this, may I request Dr. Sanjay Agarwal to introduce Dr. Janki Ram, please.
So respected Dr. Ogle, who is the chairman of our LH Hiranandani Research and Foundation, Dr. Sudhakar, Dr. Medikiri, and dear friends. You always hear like Janki Ram needs no introduction. But I will give some introduction. He is a dear friend. You have seen his expertise today also. Janki Ram is one person who popularized our branch and uplifted our branch in India and rest of the world. So I am very proud, dear friend, for all your contribution. And now I invite you to give the oration.
Check. A very good afternoon to all of you. Respected Professor Ogale sir, respected Chairman of this prestigious Mid-AOI Con, Professor Sudhakar Vaidya sir, Professor Sanjay Agarwal sir, President of AOI, prestigious AOI Association, Professor Medikri sir, Professor Kaushal Seth sir, Professor Viral Chaya sir. I can keep on naming people who are very close to me, but let me start my topic. I first of all thank Professor Sudhakar Vaidya sir for giving me such a wonderful platform and to talk about a legend oration in his name, Professor LH Hiranandani sir. So I know a little bit about him. I just want to tell before I start my lecture. Professor Kirtane sir, I did my fellowship under him for 3 months. He used to say, there is one great person you know, Dr. Hiranandani sir. You know how he is great. He used to practice till 90 plus years of age. That's what I heard from him. Maybe I'm wrong. So he had a clinic in his upstairs, and then he used to lock the door and go, even at his 90s age. So one day what happened was his clinic got over, and then he was walking down slowly. He's 90 plus, imagine 92, 93, and he's coming down, and one patient is coming now and saying, sir, I want to meet you. Immediately there were some people, they said, no sir, doctor has already finished his clinic, you're 20-25 minutes late. No, patient has come to see me. He pulled the hand of that patient, walked up, he himself opened the door, and then he saw the patient. See, this is the humanitarian basis with which a doctor should be. And Kirtane sir used to say this many times, and that is why today we are remembering such a great person. So I think we should give a big hand for Professor Hiranandani sir, who is a legend of legends. So he's a legend of legends. So with this brief introduction about whatever little I know about Professor Hiranandani sir through Professor Kirtane sir, the topic given to me is juvenile nasopharyngeal angiofibroma. So I want to talk about this topic because it's very close to my heart. I spent roughly around 8 years of my life decoding this tumor, because I have seen Professor K.K. Ramalingam sir. He is my guru. For the past 5 years I worked under him. So I have seen him only like a hero doing JNAs. That time MMC, nobody used to do JNAs and all. So he used to do JNAs. But the unfortunate thing was we couldn't see because there were no endoscopes. That time there were no endoscopes. So he used to do Wilson's transpalatine approach. and then he used to use a curette, and then of course, you know, it bleeds, GNA bleeds, and so we used to go and collect a lot of blood from the blood bank. This is what I knew, but I definitely know that till now patients come without recurrence. How did he do that? It's magic. This is what I know about Professor KKR. But then I thought, this one tumor which we have not studied too much, we have to do something, Because I don't know if you have seen my stories I write in Facebook. In fact, I'm so privileged that my biography is going to come out. It is being written by one professor of physiology, and you will see how I went into all this. So she's writing it in detail about it. So to encourage the young ENT surgeons. So one professor in Germany, his name is Arnold, I can say his name also. He was operating on a stapedectomy. And I was a small boy. I was like this small girl who was there. I asked him, what are you doing? So he injected some solution here, and he used a micropipette, and he was sucking something. I said, to my little knowledge, if you suck the perineum, what will happen? You will have SN loss, right? So I told him, sir, how do you say this is going to cure? I asked him, what is that injection? He said, I'm called Ram. Ram, this is steroid. I'm injecting steroid, and I'm just doing some test. I said, how is it going to cure autosclerosis? And then he said, please listen to me. Then again I asked him, sir, why are you using micropipette to remove perilymph? You are going to cause SN loss. He got a little angry. He said, Ram, we form concepts. You go and follow it back home. Exactly the sentence he told. And when he told, basically I'm a little egoistic I was then. I was a small guy, got gold medal, this, that. So I got terrified. What? You form concept, that means what? I'm a goat or what? To follow your technique. That day I caught my flight from Munich. I came back to Chennai. I was literally crying. I said, why we Indians should get a name like that? At one day, I will form concepts, you will bloody read, man. This is what I thought. This is exactly what I thought. Then I came back. I said, no, now I will start burning everywhere. We form concepts, you got. The first thing I have to write is publish paper, write books. This is what I knew. So, where to start? Mastoid means Mahadevya sir, everything finished. All autology, everything finished. So, I thought, okay, this tumor is a little sinister. Let us do some research. So that is when I started at the age of around 31, 32. And then I published many, you would have seen my Facebook also. Wherever there is a JNA in India, I'll do it free of cost. I went, I spent my money, did it free of cost. And slowly, I untied the knot of JNA. So this is how the concept has been created. I want to start saying that I am from a small place called Trichy, which is a small city. This heading was actually a heading given by Professor Ricardo Carrao in the World Congress, American Congress, the good, bad and ugly. And that is actually, I stole that heading from him. And next slide. So, next slide. So this is the place where I live. I request that you all come to Trichy, and it's a fantastic place. You can come free of cost. You can stay in my house if you want, and I will also teach you whatever I know. So you can come for fellowship. Next slide. Now, the first thing, if I have to study a tumor, I have to study small tumors. I cannot see in India you find very big tumors involving the infratemporal fossa. So I got luckily 6 cases at that time from Assam. Some Gautam Count, I don't know if you know him, they are all very close friends of mine. They referred some cases. And that was the click for me. That is where I got the fire. Now, they were calling it juvenile nasopharyngeal angiofibroma. That means what? Juvenile means in a juvenile patient. Nasopharyngeal means it should always be in the nasopharynx. Angiofibroma is angiofibroma. But you see this case. This case was referred to me again. It didn't have any attachment to the nasopharynx. That is when I published, it cannot be called juvenile nasopharyngeal angiofibroma. It should be called juvenile angiofibroma. In fact, the world now calls it juvenile angiofibroma. If you don't know, you can go to any World Congress. They don't call it JNA, they call it JA. It's called JA. So this is the first concept we formed. Second concept we formed out of the 6 cases were the JNA was arising from a place called the pterygoid wedge. So I went through the literature, and Professor Schick from Germany had already told this. Because it is a completely, vascular region full of marrow, he had published a paper long time back. Then I got that paper, I read that paper completely, and then I thought, okay, then if this is going to be the site, then how does it correlate with me? So I found all my own recurrent cases coming back when I left the pterygoid wedge area. This is how we found the site of origin was pterygoid wedge. Now, then we presented this sign called the Ramharan sign. So Bavaharan was the radiologist. We did a lot of work on around 132 cases. We studied the scan and found that this pterygoid wedge was enlarged compared to this pterygoid wedge. So then we read about the 2 signs, Hallman-Muller sign and Gondosa sign. They were not present in 40% of JNAs because it has to come to the infratemporal fossa to widen, push the posterior wall of maxilla anteriorly. So then what is more consistent was our sign. So that is when most of the Brazilians, they started following this, and if you go even to Brazil now, they say Ramharan sign is the best sign for JNA. Next slide. Now, I thought, then I analyzed this tumor according to classification. All the classifications, whether you see even today they are talking about septoplasty, Cottel's line, all that. To me, it doesn't make sense at all. Why? These are all in the pre-endoscopic era. It's all the pre-endoscopic. Now we talk about endoscopic septal correction. We don't talk about anterior septoplasty, posterior SMR. This all is gone now. We talk about same way, all the classification, Radkowski's classification, Fish classification, Andrews classification, everything were in the pre-endoscopic era. They were not using endoscopes to operate. They were doing lateral rhinotomy, Weber-Ferguson, they were doing Wilson's transpalatine, and you see the sites they have mentioned, totally absurd. Then I thought, let us form a classification. And for that, we should read at least 150 JNAs. Now, then I started thinking about it. Again, every day, night, I used to think like how I am thinking today about skull-base osteomyelitis. Every day now, for the past around 3 years, I have been thinking only skull-base osteomyelitis. Now, I am going to call 4 volunteers from Dr. Deepak Pulwani, who is my student. 4 volunteers, please, I want. I don't want girls, I want boys. Yeah. If some junior boy can, come. Oh, this is just for juniors. It's not like, I don't want to say it's a rocket, this one. It's a very simple stuff. Come. Now, see here. Stand here. Come here. Stand here. Okay. Come here. Stand here. Okay. Stand. Okay. Now, see, this is what JNA is all about. This is all I conceived. So I am looking like this. I am looking from here. This is the nasal cavity. This is the posterior wall of maxilla. This is the sphenopalatine foramen. This is the pterygoid wedge. And behind is the sphenoid sinus. Okay, clear? Can you understand this very clearly? This is the posterior wall of maxilla. This is the sphenopalatine foramen. And this is the pterygoid wedge. So just behind the posterior wall of maxilla, that's medial, this is medial, that's lateral, will be the pterygoid wedge. Please understand this. He will not be there. Just 1 second. He will not be there. If you look at it, only this part will be the pterygoid wedge. Now, see, what happens to the JNA? JNA starts here in the pterygoid wedge. Okay. Now, I saw all the articles in that they are told JNA follows the pathway of least resistance. Please see the previous, before our book. Pathway of least resistance from here, even if it's in the nasopharynx, what is the pathway of least resistance? Oropharynx, no. How many JNAs have you seen in the oropharynx? That means the theory is wrong. Immediately I said, no, this theory cannot be correct. If it is going to be a nasopharyngeal angiofibroma itself, it has to go to the oropharynx, pathway of least resistance oropharynx. We are not finding any JNA in the oropharynx. So what does it do? That means it is not also in the nasopharynx. It is starting from the pterygoid wedge. So I form my own theory. So what happens is this is supplied by vascular, some vascular. So here, what is the artery near the pterygoid wedge? The sphenopalatine artery comes like this and it gives out the posterior septal branch. So what happens, the JNA goes like this. It starts enlarging either into the sphenoid sinus or into the nasopharynx, and then slowly it pulls along the posterior septal branch and then looks at the sphenopalatine foramen. This is sphenopalatine foramen. Slowly it goes and gets here. This is the JNA. I am the JNA now. I am the JNA standing behind the maxillary sinus in front of the pterygoid wedge, widening the sphenopalatine foramen. So what is this area? This area is pterygomaxillary fissure. This is the pterygomaxillary fissure. So this JNA, it is caught the sphenopalatine artery. This is a descending palatine artery. It will catch along this internal maxillary artery as well as the pathway of least resistance. It will go into the infratemporal fossa. This is how it spreads. Very clear. See this. See how beautiful it is. It starts here, pterygoid wedge. Then it can either bulge, because pterygoid wedge is a nicely bony covering. So it will go into the, it has to go into some space, into the sphenoid sinus or nasopharynx, catches hold of the posterior septal branch, then sphenopalatine artery goes into the pterygopalatine fossa, pterygomaxillary fissure, infratemporal fossa, and then it goes to the cheek. That's how it presents to the cheek. Now, this JNA is very clever. This JNA is very clever. Come. Now, this JNA is very, very, very clever. How does it go? This JNA, it goes into the pterygopalatine fossa. In the pterygopalatine fossa, it will see up. If it sees up, what is there? Inferior orbital fissure. So it will go like this. Inferior orbital fissure is there. What is the artery? Infraorbital artery. It will catch hold of infraorbital artery, it will go into the inferior orbital fissure. That's how it widens the inferior orbital fissure. But if you see, inferior orbital fissure, it will never come in front. Why? Inferior orbital fissure doesn't have any connection in front, because it is covered by a layer of dura in the along the V2. But inferior orbital fissure continues into the superior orbital fissure. That's how it goes into the superior orbital fissure. And then this guy is there here. Who is he? He is the carotid artery. So it goes here. Where is this area? This is the cavernous sinus. So that means it's so predictable, this JNA. It goes here, it sees up, inferior orbital fissure, superior orbital fissure, cavernous sinus. It never goes behind the carotid artery. Why? Because the carotid artery forms a nice barrier for it. Most of the JNAs are seen along the anterior wall of the cavernous sinus. It's never seen, generally not seen along the posterior wall of cavernous sinus. Okay, fine. So I understood, okay, this is actually, see, so from here, it goes here. One, anterior spread, lateral spread. So I named it anterolateral spread of JNA. That's how I published it. So this is anterior, lateral, cheek. Now, this is antero-superior. It goes inferior orbital fissure, and then once it goes behind, see, this is all supplied by external carotid artery, mainly the internal maxillary artery, branches of internal maxillary artery. Okay, some JNAs now, it's gone to the nasal cavity, nasopharynx, occupied the pterygopalatine fossa, infratemporal fossa, pterygomaxillary fissure. Where is the space for it to go? Then it starts thinking, JNA starts thinking, I am JNA. I start thinking, I start moving posteriorly. Then only the difficulty comes. How it goes posteriorly? Pterygoid wedge. Pterygoid wedge continues along the quadrangular space. So it goes along the quadrangular space. And then where the quadrangular space ends, it ends in the Meckel's cave. It is the doorway to Meckel's cave. Inferior orbital fissure is doorway to superior orbital fissure. Quadrangular space is the doorway to Meckel's cave. Meckel's cave is lateral to the carotid. This is a carotid, this is a Meckel's cave. It goes here. And once it goes here, it can go into the temporal lobe. But extradural. Dura is a very nice barrier to JNA. Thank you, my dear friends. Give them a big hand. Okay. Sorry I used them, but then to make the juniors understand. It's an easy way to understand. So, am I clear, Professor Sanjay sir? So, this is very simple tumor, very easy tumor to understand. If you just know the pathway of spread, nothing like it. So, I just classified. See, pterygoid wedge, extension to the nasopharynx. It's the simplest classification. I don't know why people talking about this, that. It is according to the route of spread. Nasopharynx, then where it will go? It will go into pterygopalatine fossa. I told it went to pterygopalatine. Then it will go to infratemporal fossa, 2C, 2B. 2C will go into the inferior orbital fissure, superior orbital fissure it can go. Then after 2C, it gets blood supply from the internal carotid. It goes into the quadrangular space, Meckel's cave. Then it will surround the carotid, cavernous sinus. Then it will not know where to go. Here it is the infratemporal fossa, everything jam-packed. Where it will go? It will go into the parapharyngeal space. Infratemporal fossa communicates the parapharyngeal space. Last it will start going to the parapharyngeal space or it will go into the intracranial cavity. That's all, boss, JNA. This is the knot of JNA. So if we understand the simple thing, see, unless you understand the spread, you cannot do any tumor. Same in skull-base osteomyelitis. Many people have not understood. Today I showed you all the pathways. I'll show you tomorrow. This is the spread. Once you understand the spread, you will definitely conquer the disease. So, the next slide. Now you see. Now I will just show you simple one. When I say stop, you stop. Let's just say 3A. 3A means what? It is going towards the cavernous sinus. Very clear. Okay. Now, next. Now, stop. Now you see here, this one will have columnar sign because going to the infratemporal fossa. Always look for the arterial supply. See, this is the arterial supply. See, this is the IMAX. Okay, this is the IMAX. IMAX comes like this. It comes like this through the medial lateral head of lateral pterygoid muscle and goes like this. Tumor is arising from here. But what happens to the tumor? It holds the sphenopalatine artery and then it goes like this to the pterygopalatine fossa. So where the IMAX will be? IMAX will be lateral, correct? But once it starts progressing like this, what it can do? Either the IMAX can go posterior or it can go anterior. So this is simple. Very few cases it goes anterior because more posteriorly so much of fat. So usually it will be seen in the posterolateral region. So you see here also it corresponds similarly to the posterolateral. It's all very basic logic. So what you do? Everybody is talking about embolization. I am telling you, I have talked in several congresses, including Professor Stamberger, everybody sitting arguing. You don't have to do anything. You just do a Denker, go here, move this, ligate this IMAX. This is the main blood supply of the internal JNA. If you do a DSA, believe me, if you do a DSA, you will scratch your head. They will give hundreds of small vessels, that will not cause anything. I am telling you, unless you have a major bleeder from the ophthalmic artery or a major, which is very rare in my, I've done more than 500 cases now. So I am sure that you don't have this and all. It's basically the IMAX, very small twigs from the ascenic pharyngeal, very small twigs from the middle meningeal. That's all. And you don't have to ligate them also. If you ligate this, the tumor is dead. So you don't have to embolize. Why you want to embolize? You don't have to embolize. So you go with a coagulation, but only problem now is now you are using too much of coagulation. Please understand, don't coagulate a vessel and leave it like that. Because if you coagulate, I myself have seen after 20 days, 15 days, they land up with massive hemorrhage. Recently we had an hemorrhage, right? One person actually discharged. 16th day, the patient has a hemorrhage from Hubli, right? Hubli. And the doctor has come, phoned up. We have not even gone there. It's a nasopharyngectomy. Patient has had a secondary hemorrhage from some other branch. It's a nasopharyngectomy. But what I mean to say is if you use too much of coagulation, incidence of secondary hemorrhage is very high. Be careful. You clip it or use diathermy nicely and then you coagulate. Or coagulate and use diathermy. Never stop it. So next step. Go ahead. So what you will do in this case? What you will do next? So stop. So what is this area? That means what? it has gone to the sphenoid sinus. Okay, it has gone into the nasopharynx. Pterygoid wedge, sphenoid sinus, nasopharynx. Gone into the pterygomaxillary fissure. This is the cheek, this is the mandible here. Gone into the inferior orbital fissure. Widened the inferior orbital fissure. Gone into the superior orbital fissure. इतना ही है, इसमें कुछ भी नहीं है, JNA में कुछ भी नहीं है. And where it will go? It will go into the anterior wall of the cavernous sinus. Next slide. See, same. You just have to see. That's all. This is the cavernous sinus. So this is intracranial extradural. This is the carotid artery. This is the intracranial extradural part. Here you don't have to do anything. You just have to gently pull it. It will come out. It's called the gentle pull. Now slide. Now you can play the video. So how we are going to do? Basically, I believe that we have to do a four-handed technique. You can see here. I do a go ahead. Posterior septectomy, and then I do a modified endoscopic Denker. Of course, I respect whoever is doing JNA. There are many people. Dr. Satish Jain is doing a fantastic job. Dr. Renuka Bradu madam is doing a fantastic job. All are doing a very good job. So you learn whatever is best for you. I don't say this is the best technique, that is the best technique. Everybody has got his own technique. So I use more of cold steel instrument. You see, it's more of cold steel. I ligate the IMAX. Once I ligate the IMAX, this tumor is dead. And then what I do, I use more of drill and then slowly get that tumor from the V2. The main thing is to separate that tumor from the V2. Once you separate the tumor, you can deliver the tumor out. See that tumor. And then this is the cavernous sinus. You can see that's the anterior wall of the cavernous sinus, and you can see the nerves going there, superior orbital fissure, 3, 4, 6 nerves. And then you will beautifully take that out, and you can use a Doppler if you want. How many minutes left, sir? Over? 5 minutes? Okay. So we always drill the pterygoid wedge. We always drill the pterygoid wedge and get that out. So this is basically the surgical treatment for JNA. Of course, we have some difficult cases like this. This case was operated by top-notch ENT surgeons of the world, not India, of the world, which I revised. It was operated 9 times. And I operated in a different country. And you can see that this is a four-handed technique. Me and myself and Shilpi, we are doing this surgery. This is the infratemporal surface of greater wing of sphenoid. And we can see that we are dissecting it. So everything is done under vision. And you can see that the carotid artery, I just want to mention only one thing. Carotid artery, don't be really scared of the carotid. Carotid at certain places are covered by periosteum. Nice endosteal layer is there. So you can actually peel that. When PJ Ormal saw this, oh, why are you doing like this, he said. I said, boss, you would also see the carotid artery. I'm coagulating the infralateral trunk here, and that's a carotid right there. I'm going to peel this carotid from the carotid, peel the JNA from the carotid. So I'm getting a proximal control. Proximal control and distal control are very important when you deal with any major arterial circulation. Please remember, if there is a bleeding, you should have only 2 things. One is you should have adequate space for you to put a clip. If you have a narrow area, bone surrounding it and bleeding like that, you cannot do anything. You have to only put the unipolar, even bipolar you cannot do. So usually what I do is, I get a, see how I'm peeling that from the carotid artery, see the carotid artery there. It's right from the carotid artery I'm peeling. So if you have adequate space, you don't have to worry at all. So not that, you do it immediately, just do some dissections and then do it. So I think I'm going to stop here because I'm not going to. Are you sure? Because I don't want to take too much time. Okay, now I'm just giving you an example of this. See here. No. So I request you all to visit 2 centers. If you want to do good skull-base surgery, please visit 2 centers. Number 1 is Varese. Varese in Italy, the youngsters. Second is Pittsburgh. So these 2 centers, if you have a chance in your lifetime, visit them. They are the best centers in the world. I learned this technique from that center. I went there. Of course, I was the faculty. I went there. But I learned it also. That's one advantage. So you put the previous scan. See, this is the massive parapharyngeal extension. This is a stage 4A. How will you remove this? How you have to do a maxillary swing and all this stuff. Whereas there is a new technique as proposed by Professor Dalan. Ayopo Dalan is my very close friend, and he has published a technique called the transoral technique. So, slide. You should know about all these latest techniques. Of course, if you had given me time for the dissection, I would have shown you all that. So here we see, this is a tonsil. This is a tonsil, this is a uvula. Make an incision along the anterior pillar. Put it. Now see how I'm making the incision there, and then I use a artery forceps as given by the tonsil artery, and then the tumor. You can see the tumor. This is the lower parapharyngeal space, and then you can bring the tumor. I'm bringing the tumor now upwards. So you can deliver a the parapharyngeal tumor from the oral cavity to the nose. This is the first case described in the world literature. I have published this in the European journal. Which journal, I don't know. I will give you the reference. So you can go through transoral technique to nasopharyngeal angiofibrom. This is a foramen ovale. So I am cutting the tumor at the level of the foramen ovale and bringing the tumor from the oral cavity into the nasal cavity. So without making any external scar, no Weber-Ferguson incision, no lateral rhinotomy incision. Of course, not that you are great by doing endoscopic, but if you know this technique, you can show this. Definitely, without a scar, you are doing this. See that? I am removing that through the nose. From the oral cavity, I am bringing it through the nose. So this forceps is called Takahashi forceps. All of you get this forceps. If you want to do JNA, get this forceps. It is not Blackesley. It will not catch. It will slip. This is called Takahashi forceps. Next slide. So once you remove, you see this. See, always take a post-op scan. You will know definitely whether you removed the tumor or not. All JNAs from our center, we take a post-operative scan on the 7th day. So you should take a scan on the 7th day. Tell the patient truthfully what you have left behind. If you have not done that, you are not truthful. Some people say you come after 3 months. Next slide. Now you see, this is a tumor again, first time in the world. This was published in Asian Journal of Neurosurgery. See here, this is a dentorial branch. Today I showed you the meningoepiphyseal trunk. This is a branch of the meningoepiphyseal trunk. This is the intracranial part of the JNA. So what did I do? I could have asked for a pterional incision, but I didn't. Next slide. That I learned from Castelnuovo. This is called the transorbital approach. I don't know if you know Dr. Sriram Murthy Garu. You know him? He talks too much about this approach. It's called TENS or something. He has learnt a lot and he's doing a lot of cases. I like it. So this is a transorbital approach. You see, this also I could have shown it to you in the cadaver. This is superior orbital fissure. This is a greater ring of sphenoid. And once you drill this greater ring of sphenoid, you are in the orbitomeningeal band. And once you cut the orbitomeningeal band, you are in the middle fossa dura. This is the dura in the brain, temporal lobe. The tumor is occupying the temporal lobe. And so we gently take it through the eye, we take the JNA out. So this is again published first time in, the whole world. We have done this case and we published it also. Why I am telling this is because I always believe that honestly boss, I have been seeing the whole world. The whites, Syrian is here. They think that, they have what is that? Please understand, we also have 1.5 kgs of brain. Anybody has got 1.5 kgs of brain. Please understand that. And start thinking that, what are you talking? Let me also talk. This attitude should be there. As an Indian, you should all uplift the speciality and bring it to the whole world. I always believe that. See this post-operative scan. And that will happen only by publications. Next slide. So last slide, this is again the only center in the world where we have done this, is where the carotid artery has been completely engulfed by tumor. Next slide. See this tumor going towards the temporal lobe. Can we do it endoscopically? We did it endoscopically. Next slide. So you can see here, this is how we did it. So today you saw the carotid artery, right? So we coiled the carotid here. See, that's the laceral carotid. That's the clinoidal carotid. We put 2 coils here and I cut the carotid. I cut the carotid and removed the tumor along with the carotid. Next slide. We have done 7 cases like that. See, this is the post-operative picture of the temporal lobe. This is the post-operative scan. See here the post-operative scan. I am not joking actually. This is what we have done. Next slide. So we have done a lot of cases like this. See that tumor going right to the temporal lobe. This case I employed a neurosurgeon. Next slide. He did a pterional craniotomy. Next slide. And this was the 3D planning of that case. So we did a 3D planning where to meet. The neurosurgeon comes from here, I come from there, I meet exactly at that hole. That hole was the cavernous sinus. Next slide. So that was the preoperative planning, and he did it from outside. This was the postoperative scan. See the complete removal of the tumor. Next slide. So stage 5, of course, this is we have not yet published. This is the Jenica approach. Next slide. So you can see the tumor this was referred by Professor Suma from Kerala. From here to here, the patient presents with stridor. So you can see here, this tumor, we did a bilateral maxillotomy, mandibulotomy approach, and we removed the tumor completely. But 6 years later, the patient had a recurrence, and then again we had to operate. Dr. Suma knows about this. Next slide. And this is another case. You can see this case. How the patient actually put one cloth and came because he didn't want to show his face. It was disfigurement and snoring, severe snoring. You see this was the tumor, and we removed it with the Jenica approach. Next slide. So these are indications for me. See the postoperative scan. These are indications for external approach. But having told that, I'm finishing it by just the last slide. Everybody, please understand, has his own complications. Don't ever think that I am a guy who is without complications. Every day we face complications. And a good surgeon is one, I always say this, not that he's a super surgeon. A good surgeon is one who can handle his complications. This is very, very, very important, my dear friends. See this complication. This was 13th time patient was operated and sent to us. And I operated. I didn't understand any anatomy. I was drilling at the level of the superior orbital fissure, and see what happened. So I was thinking it's the endosteal layer of dura above the carotid. Now I started, so we gently incise the dura, the endosteal layer. See here, see that, what happened. So, you know what I do when I have a complication? I just shout at my resident and say, record. That's what I say first, because I want it on paper. And we published on JAMA also, we have five carotid bleeds. We have published it along with Pittsburgh and Ohio State. So you can see that publication in JAMA. So of course this patient, we could shift him to the endovascular team, and we could save him by a coil. So, but we lost one patient out of 5 patients, we lost one patient. So I just have to be honest about what I do. I face complication, again and again I say. So don't think that anybody who does super stuff doesn't have complication. He will have. So if you want more details, this was the first edition. The second edition is coming up. I'm writing a lot more about JNA. Next slide. So the take-home message. Yeah. This is the take-home message. Whenever you do any skull-based surgery, don't work on narrow corridors. See, this is what you will do. Many people, they say, oh, don't cut the inferior topinate, don't cut the middle topinate. This is so. If you do that, you cannot do a JNA. Please understand. Because if they start bleeding, you will just have to pack. You cannot visualize any artery. So this is what, you will look like a stupid surgeon. So exposure is the most important thing for any skull-based surgery. Don't act like a rhinologist. Rhinology is different. Skull-based surgery is different. Number 2, you should always have vascular control. So if you're dealing with JNA, you should have IMAX control. If you don't, this will not happen to you. See that? You will fall like a surgeon. And third important thing, you should, again I told you, today also you go get the anatomy of the ICA. Or else see, that's a surgeon, the ICA. It will just bite you. But with more and more dissection, what he's doing is more and more dissection. Surgeon is doing dissection, temple bone. Then you see what happens. He will hit like a football the ICA. So thank you very much. And thank you, my dear chairpersons. Thanks a lot.
Thank you very much, Dr. Jankiram. To have a person like his caliber is just a blessing to our hospital. One incident I would like to narrate. I visited Australia in 2017, and one of the senior ENT surgeon from Singapore was giving a lecture on JNA, and actually it was around 4 o'clock, same time, and I attended that lecture because he was such a renowned person, and he was showing slides of Janki Ram.
No, I want to tell you one thing. I faced it right in India. It was Asia Oceania. You were all the people who conducted the Asia Oceania. There was a doctor who is my teacher who introduced that, you know that Australia took out the next, you went to Australia, right? The next time. So the Australians had come, 5 Australians had come. And the teacher who introduced me to them, saying that this guy is a good surgeon. And you know the Australian, sorry to tell you, the Australian attitude is different. अरे क्या यार जो तो बकवास कर रहा है. This is what they think. Okay, then they didn't even bother. I said, hello sir. I usually am a humble guy. I just say hello sir. They didn't even bother. I see the body language is very important. I can easily judge a person by his body language. They just walked away. Then somebody told him, tomorrow 8 o'clock this fellow is doing a live surgery. Somebody has told him. Then I watched, silently I watched. First person was sitting is the Australian in the hall. Okay, after that, after the surgery, it was in Asia Oceania. I think I operated on a JNA or a pituitary. I don't know what I remember. After that, I was sitting in the coffee shop. Okay, I was just sitting. I was just watching the Australians. They were searching for me. I clearly understood they were searching. I turned, immediately I turned. Then they came here. They came to me and then they sat near me. They said, I am. Then I said, Vada, we are Indians. Vada. I told like that. See, it is not that we have that head weight, but they should not take us for granted. This is something which I don't like, and I want to say proudly that I am an Indian. This is something which I want every Indian to be like that, not only me. Thank you.
Yes,
Thank
this is
you
a
so much,
oration,
sir.
no questions are allowed.
Thank you so much, sir. We are always very much mesmerized by your words, experiences, and anecdotes. Now, to felicitate Dr. T.N. Janki Ram, I would like to invite our respected chairperson, sirs, Dr. Sanjay Agarwal, sir, Dr. Ogle, sir, and Dr. Ved. And along with them, I would also like to invite Dr. Shankar Medikari, sir, and Dr. Kaushal Seth, sir, to please join us on the stage. Okay, before we move on to our next session, we would like to felicitate the chairpersons for the last session. Sir, Dr. Sanjay Agarwal, I would like to welcome you on the stage again. And to felicitate Dr. Agarwal, I would like to welcome Dr. Sudhakar Vaidya. For Dr. Sudhakar Ogle, I would like to invite Dr. J.K. Sharma. To delve into the exciting intersection of AI and hearing technology, I invite Mr. Anup Narang to share his expertise. He is director of well-established firm ELPS International Private Limited, highly recognized and doing wonders in manufacturing broad assortment, best quality digital hearing aids and rapid fit aids. And for this session, I would request Dr. Anil Jain and Dr. Yashveer Kedalia to please chair the session. Sir, please, we would like to join you on the stage.
So artificial intelligence is really coming up everywhere. I'm a faculty in the medical college. We see thesis being written now through artificial intelligence. So it's approaching everywhere, and I request Mr. Anup Narang sir to start your talk. So innovations in hearing technology.
Thank you very much, Chairperson, sir. Also, thank you very much to the organizers who have given me the opportunity, and I'm honored to have such an august gathering. Before I begin, all I want to say is Professor Dr. Janki Raman, an actor, a sportsman, a doctor, a great human being, and a guy, sorry to use the word, a guy who makes you feel you're an Indian, and let me tell you, you are empowered, and let's take India to the world. So that's your inspiration to all of us. Thank you very much. And beginning with AI application and technology. The word AI excites our mindset. We are often wonderstruck. We think about many different things, often forgetting the fact that it's all human intelligence and human creativity which is continuously innovating. But then all that when set together and then coming out at the right time is what artificial intelligence is all about. We in India are blessed to be having the largest force in the world today, who's a force of software developers working in the field of software development, of course artificial intelligence, and that's what is today helping the technology of India advance quicker than Europe today. There's a lot of question marks about potential uses of artificial intelligence, what it can do, etc. And I just want to add on here a small quote by Einstein, which says, "The measure of intelligence is ability to change." In this endeavor, India has developed some very fine medical devices over the last 4 to 5 years today, which are being used across the world, including United States, including Australia, many international markets. Now here I am going to present to you probably the world's first wireless hearing aid with interface-free programming. Interface-free programming essentially is the point, because whenever a hearing aid, a patient is programmed in your center today, and he has left, say, to London for a conference, and he's sitting in his conference for a 2-day meeting, he calls you and says, you know, I'm missing something, something is not right. And that's where you tell him, okay, you probably need a fine-tuning or a pre-programming. You may need to go to some center in King's Cross, and near there, he says, you know, I'm here for 2 days. There's no way I can come out. Now this, I worked with the Indian Institute of Technology. We've been working with them for over 4 to 5 years actually now. And they developed for us the I2S technology in hearing aids, first time in the world, where your patient sitting in his hotel room anywhere in the world, switching on his mobile, which is paired with his hearing aid, and you are connected to him through your mobile or through any desk or any way, you will be able to program it right there and then. So this is something which India is giving to the world. Just a small film. I'd like to.
In life, as on the golf course, it's the moments of careful precision and quiet concentration that carve the path to our most fulfilling achievements. Meet Nilo, the hearing aid where advanced technology meets elegant design, ensuring you never miss the whisper of the wind or the applause of success. Nilo embodies wireless freedom, rechargeable energy, and seamless Bluetooth connectivity, enhancing every sound life offers. With Nilo, experience life's beautiful symphonies, from the subtle rustling of leaves to your favorite tunes, streamed directly to you. Nilo, precision hearing, perfected for life's every moment. Immerse yourself in the clarity and connectivity designed for the discerning ear.
So this is developed at these facilities which you see in front of you. These are our production and design facilities at Ghaziabad near Delhi. Many of you have been here as well. And now AI, how it personalizes the requirements of the patient is very interesting, which I want to share with you in the next few slides. With all the facilities, the greater part is the top line, remote programming without use of any interface. Of course, hybrid technology, 2.4 gigahertz wireless technology, all these inputs have already been present for a few years. Some of the practically oriented features which are very useful for patient fitting have been incorporated, such as the audiometry has many options: in situ audiometry, automatic in situ audiometry, audiogram inputs directly from an audiometer. All kinds of features are available. The synchronization technology, the synchronization is another added advantage which is there in today's new products like the Nilo. Now, the technology which we talk about in jargons must be able to help patients to hear in dynamically changing listening environments. And I want to give you a small demo of how the hearing aid will activate in different listening environments using artificial intelligence. Now, what new has been added, you will probably appreciate as you will probably hear it in your own ear. As you know, noise cancellation has always been there for the last 10 years, since digital technology came in and later, about modulation and with modulation, cutting out the noise and keeping the speech alive. Now, this is a new technology where we talk of shifting noise floor. That's the new technology which India is giving to the world, the shifting of the noise floor. Just keep your eyes on the red arrow and see
अब्राहम लिंकन को महानतम अमेरिकी राष्ट्रपति माना जाता है।
See how the noise changes.
विंस्टन चर्चिल को इतिहास का सबसे प्रेरक अंग्रेज राजनेता माना जाता है। अब्राहम लिंकन को महानतम अमेरिकी राष्ट्रपति माना जाता है। विंस्टन चर्चिल को इतिहास का सबसे प्रेरक अंग्रेज राजनेता माना जाता है।
Same signal data, but how noise cancellation starts happening automatically. The hearing aid, which when once in use by the patient, will be continuing to see what's the daytime, how the patient's lifetime works. Morning, quiet of the home, then traffic, then probably a meeting or a surgery room, then maybe a party in the evening, maybe a musical show. So all these different listening environments, the patient will be exposing himself to, the hearing aid will be learning and collecting that data which I spoke to you about, and that's where the artificial intelligence will come to play. Similarly, you have multi-channel graphic equalizers. All the 18, 20, 22 channels, the hearing aid is being channelized differently. So that really enhances the hearing experience for the client. Also a small demo of advanced noise reduction. Just keep your ears on and see how it changes by the hearing aid simply learning. What you saw being done manually, the hearing aid will be learning and doing automatically for the patient. A small demo of the advanced feedback cancellation. This is an artificial demonstration because nowadays you will notice whistle never happens in a hearing aid because they already have automatic feedback cancellation built into the system, and it catches the feedback at electronic stage itself. But just a demo of how it works. So the key features essentially is real-time audio streaming facility available. You can enjoy your music, you can enjoy your smart TV, you can enjoy your phones. Lawyers very comfortably pair their hearing aids with the High Court or the Supreme Court, and they're able to hear so conveniently. They'll be able to hear the judges from a distance despite the fact that they are having a hearing impairment, and it's all being audio streamed into the data is being audio streamed into their hearing aid and into their ears. And of course, interface-free programming, which I spoke to you about earlier, telemedicine, and one very good advantage which again we have added here, which was not present anywhere earlier in the world. Whenever a patient used to connect his Bluetooth hearing aid with a smart TV, it was only he was paired to the TV, and therefore the volume level of the TV was kind of grabbed by his device. Now, while you watch smart TV and your family sits with you, they can also enjoy the smart TV at their volume level, and it is thus allowing better connectivity not only between the device and the patient, but also, of course, between him and his family. Of course, it's available in rechargeable versions as well. And not only Nilo, we have brought out and working on artificial intelligence used in many, many different hearing aid devices. You can see some of them right here in front of you. Many of you are using them. You'll be happy to know there are hospitals in the US, hospitals in New York who are today importing hearing aids from Alps, from India, and they are already being in use in the United States. Last month only, Australians have started buying our hearing aids. So, as what Dr. Janki Ram said, the time has come for India to go and reach out to the world. The technology inputs behind this high-tech development. That's our new R&D center, very near the Delhi airport at Gurgaon. Very happy to welcome you people. If anybody ever wishes to visit us, all modern automated CNC production in place. We are investing a lot of revenue into research and development. This is some pictures from our plant. And a lot of high-tech development tools in place, all pick-and-place machines, CNC machines today. Probably one of the finest hearing aid production units in the world, now in India. Focus, of course, on precision and accuracy. And of course,
ये पत्तियों की है सरसराहट कि तुमने चुपके से कुछ कहा है.
That's what the patient wishes to hear. And what's the electronics in this? Always remember the logic-based semiconductor chips, and with the ability to accelerate AI loads. It's always the load of the data which the chip has collected, and if that data is organized by the chip in a manner that the patient gets the sound which he wishes to hear at that particular listening environment where he is presently in. That is what is all about, I would say, the right electronics, the right audiology, the right ENT, and the right engineering all getting together. So the development of these state-of-the-art AI-based hearing aids reconfirms what Janaki said, India's growing supremacy in the field of digital medical devices. The time has come when the hearing healthcare fraternity needs to tell the world that India is now a solution provider to hearing impaired persons across the world. We were also lucky to receive or happy to receive the National Award from the President of India for the best technological innovation in 2016-17. We also had received the National Award in 2004 from our scientist President Abdul Kalam ji. Our hearing aids are not only being tested in India, they are being tested by labs across the world. And you must see the reports coming from these various labs, how the hearing aids today being designed and developed in India are how they are faring in global markets. So India's global leadership position is slowly coming in. Sweet sound, comfort listening, relaxed feel, that's what we expect AI to offer. But more important, we all want all of you to come together. ये कोई जगह है जहाँ हमें साथ साथ आना है, क्योंकि साथ साथ आएंगे वहीं से आगे गाड़ी चलेगी. और AI launch, we've also launched the world's first online support. If you visit our booth, you'll see a new chatbot system for online support for a patient for any of his questions, including his repairs, service, his issues of not able to hear, etc., etc. And this is moving together, which we request all of you to come together. ये कहाँ आ गए हम यूं ही साथ Thank you very much, the organizers. Thank you very much, all of you, sir, for giving me this opportunity. Grateful to you.
Thank you, Mr. Anup sir, for a wonderful presentation.
Thank you.
You are carrying forward the same trend which Dr. Janki sir has told, to be proud of Indian. And a few points which I noticed especially, that we have to counsel the patient while giving a hearing aid. They are exposed to different environments that often even we miss to understand them. केवल आवाज़ सुनना है बोलते हैं. Actually they are exposed to different environments, and you are doing very wonderful for that. Thank you.
Thank you, sir. About the counseling part, it's become easy now because the old people say that all the youngsters are having one, so I can have one. Thank you.
Thank you. Now to felicitate Mr. Anup Narang, I would request both the chairpersons to please come on the stage forward. To felicitate Dr. Anil Jain, I would like to invite Dr. S.K. Pippal on the stage. And I request Dr. Sumir Verma to please felicitate Dr. Yashveer Kedalia. Thank you, everyone. Now moving on further, for the next session, we'll be talking about cochlear implantation in different situations. And that would be presented to us by our respected President, Dr. Sanjay Medikari. And to chair this session, I would invite Dr. Shailendra Ohri and Dr. Vishal Munjal. I request all of you to please join us on the stage.
Audio connect.
Shall I? Yeah. Good afternoon, everybody. At the outset, I would like to thank the organizers, especially Dr. Sudhakar Vaidyaji, for inviting me to share my experience in cochlear implantation. Today I'm going to talk on cochlear implantation in difficult situations. My flow will be like just one slide about cochlear implant program and how a regular CI surgery is done and CI surgeries in difficult situations, and a little bit about switch-on mapping and habilitation at the end. Our cochlear implant program is 2 decades old, and we have close to about 1,000 implants to our credit. More than 95% are children. We have also done both unilateral or bilateral cochlear implantations. Not only that, I have trained about 45 ENT surgeons in different parts of the country and abroad. It is a soft surgical technique what we use a standard mastectomy with posterior tympanotomy technique. To expose the entire round window membrane, you have to do a wide posterior tympanotomy. You should be able to see the incudostapedial joint, promontory, round window, and even the hypotympanum. So opening the endosteum of this is done with the help of a small pick, right angle pick at the end to open into the scala tympani. So if you have to open the scala tympani, your cochleostomy should be anterior-inferior to the round window. If you do anterior to the round window, you will enter scala vestibuli. So the insertion of the electrode is done at the end through a puddle of dexamethasone. This is how a posterior tympanotomy should be. So between the facial nerve and the chorda tympani and below the incus buttress, you open it in such a way that you are able to show, as I said, incudostapedial joint, stapedius, oval window and round window here covered with a pseudomembrane. So and a hypotympanic cell. Sometimes if you don't identify this, people have opened the hypotympanic cell and placed the electrode into the wrong place. So this is just a first surgery which I'm showing how the regular surgery is done for the benefit of the youngsters first. So this is how usually regular post-oral incision is taken, and we mark the orbitometer line, put these templates, both processor template and as well as the receiver stimulator. This receiver stimulator should sit at 45-degree angle to the orbitometer line, and then we do the injection, local injection, and then we take a post-oral incision and elevate the anterior and posterior skin flaps, leaving the periosteum behind. Then the periosteum superiorly based flap is elevated, so that this is based on the muscle. So when you pull it down, it will completely cover the your receiver stimulator. Here I have done a cortical mastectomy. The difference is you will have a overhanging cortical margins, not the sloping edges like done for the CSOM. Here I have exposed the incus and did the posterior tympanotomy. This is the incus buttress. Your facial canal will come here, chorda will come here, and the posterior canal wall is thinned as much as possible to have a good visual access into the middle ear. Here I have drilled the upper lip of the round window. You can see the round window membrane very, very clearly, and also the stapedius tendon. So after this, we prepare the implant bed. As you can see, the skull is thin in young children, so we may need to leave an island of bone in the center and maybe expose the periphery, the dura in the periphery, so that your template sits in nicely and in flush with the outer cortical margin. Then a silastic template is put to mark the electrode array exit and the tunnel for the electrode array, which is drilled to connect the bed to the mastoid. So here we leave an island, a small ledge of bone close to the mastoid cavity, so that your electrode array can go underneath that, so that it will not easily jet out. So we saw the implant being placed there in the bed, and now we are going to puncture the round window membrane with a 23 number hypodermic needle. So the moment it is punctured, you will see the perilymph coming out, and through this I usually inject a puddle of dexamethasone here, and here advanced bionics high-res 1J electrode is being introduced through the round window with the help of a plunger or the introducer. So this blue mark what you are seeing, you should insert all the electrodes till this blue marker comes to the posterior tympanotomy, round window or the cochleostomy if you are using it. So here it was a complete insertion. We did pack it with the periosteum. Extra length of electrode is looped into the additus, and then we also check the, apart from the impedance measurements and the neural responses, we also check the stapedius muscle reflex also. So these are the impedance measurements what you see, all are around 5 kilo ohms, And these are the responses, neural response at different electrodes. We could get all the 22 electrodes. And a post-operative check X-ray is taken to show transverse view. The electrode array is within the cochlea here, as you see on the left side. And another transorbital view. This was a bilateral implant where you could see through the orbit. You will be able to see the loop or the circle of the electrodes into the cochlea. This was done intraoperatively. This was a difficult case. As you could see, as I opened, you could see a very prominent sigmoid sinus almost touching the posterior canal wall inferiorly. Very difficult to identify the posterior tympanotomy area. We had exposed the incus and incus buttress, but still we thinned the posterior canal wall quite a bit, and we were able to open up the area for the posterior tympanotomy, and we were able to do the posterior tympanotomy also in this case to expose the stapedius and the round window also with a little great difficulty and perseverance. So you see again I was thinning there. Here I opened the posterior tympanotomy. So I am see here, this is a round window, this is a stapedius tendon, stapes. I am drilling with 1 mm diamond burr the upper lip of the round window to expose the round window membrane. So we were able to expose the round window membrane, and we were able to do the implantation through the round window also in this case, though initially it looked very difficult. You can see it here. See, I have placed the implant in the bed, and then this was a CI 422 electrode with a flange. You will see 2 white markers on that electrode array. The first marker will go completely inside, and the second white marker should be at the cochleostomy or the round window, whichever incision you are doing. So here it was again, we were able to do a complete insertion and then pack the round window. Yeah, this was again another case of difficult posterior. We had actually corner septum. We removed it and opened up. Again here a very forward sinus. So when you are attending, even in spite of thinning the posterior canal wall, even though we just were able to open like the last case, but we were not able to visualize the round window at all in this case. So what we did in this case, as you see little later, though it was very difficult for us, so then ultimately I had to do this posterior canal wall is thinned. Then I did 2 vertical cuts, one superior and one inferior I am doing here, cutting only the bone and leaving the skin still attached to the bone from here up to the posterior tympanotomy area. And then I fractured this bone. As you can see, with a periosteal elevator, I am going to fracture this bone along with the skin attached to it to open up the posterior tympanotomy area. See here now I am going to push it forward with the periosteal elevator. That opened up the posterior tympanotomy a little bit more, but still we were not able to see the round window visualization. It was only a very, very small glimpse of the inferior part of the round window which exposed. So then I had to do a cochleostomy in this case, but even for doing cochleostomy we had a good visualization because of pushing the anterior canal wall forwards. But we were able to do a regular cochleostomy. You can see the cochlea being opened up. Then I inject usually a dexamethasone in this. Through that puddle of dexamethasone we usually do the electrode insertion. So I have widened it sufficiently, about 1.2 millimeter, to allow about 0.8 millimeter electrode to go through smoothly. See here I am introducing the electrode again. This is an advanced Bionics 1J electrode. With the help of introducer we were able to introduce it completely, and there was no issue. This is how we handled this difficult situation. Now coming to another difficult round window. Normally this you see the incudostapedial joint. So your round window should have been here. It was completely covered by the bone. Otherwise lower down is the hypotympanic cell. You should know the judgment, about 1.5 to 2.5 millimeter below the oval window you should get the round window. You can't open up this. This is quite below. If you open up this you will go into a false passage. See this bone which was covered, so I tried to remove it. I removed it and then exposed the round window. So which we will see in the next. See I am drilling here that bone. So I opened up and gave me the location of the round window. So further drilling exposed it further. So after complete opening of the round window membrane, so you could see now, so the totally hidden round window has been opened up, and then I punctured it. And actually this was done in one of my mentee centers. So I allowed him to do the insertion of the electrode. So I was a little struggling initially, but he was able to do. This was again CI 422. This is the opening in the round window. So he's trying to insert it. First shot he was not successful. Then with the second attempt, then he held it with the advanced by the AOI forceps, and then he was able to do the insertion. You could see it is entering into the cochlea through the round window, and he was able to do a complete insertion. In this case, the difficulty was to identify the round window. That is also very, very important, not only just the insertion. So we were able to do again a normal incision and a good responses for all the electrodes in this case. So this was an 11-year-old boy with a post-meningitic hearing loss. As you could see on the scans, there was some amount of 1 year after the meningitis he had come. There was already some amount of fibrosis in both the basal turns. So in this case, we used an electrode by Cochlear, which has got double electrode. Instead of 22 electrodes on one, 11 electrodes in 2 electrodes. So here we did a regular mastodectomy, posterior tympanotomy, and then I did the first cochleostomy anterior-inferior to the round window. After that, I removed the incus buttress, but I was not sure whether all the electrodes will go. And then we did a second cochleostomy in the second turn. The second cochleostomy, usually for that, you have to remove the incus. After removing the incus buttress and identify the area anterior to the oval window, you can see now where I am drilling just below the processus cochleariformis. This will open up the second turn of the cochlea. So when you are drilling this, your drilling should be more vertical. Don't keep it slanting, because just in front of that you will get the carotid artery. So once we did this insertion, then we took this implant, double array implant. First I put this second array, apical array, because this can go second cochleostomy either antegrade into the third turn or it may go retrograde into the first turn. So out of 11 we were able to put about 7 electrodes. Then I put the basal electrode through the first cochleostomy, where again we were able to put 8 electrodes. So out of 22 we were able to put about 15. So about 2/3 of the electrodes if we are able to put, so you can manage these patients with frequency transposition and mapping. This was another case which was a common cavity. As you can see here, the whole labyrinth is formed by just one common cavity, and an MRI you could see a nerve going to this cavity here. This was a nerve, a common nerve. So when we open this, you don't find anything in the middle ear, but the area where you normally find the lateral semicircular canal, there the common cavity will be. It is opened just like this with an elliptical opening. Then we use a straighter from cochlea. So we held and created a loop, held the tip of the electrode, that is 22nd electrode, and with the forceps and claw, we are able to push it. One should remember that these cases, the neuroepithelium will be in the periphery of the cavity. So you should see that your electrodes go in the periphery and then put a pack, connective tissue, pack in the middle. So as you can see in this X-ray, so the whole electrodes are lying in the cavity, periphery of the cavity, and we were able to get, except the first and the second electrode which were outside, we were able to get the neural responses. Though because of common cavity, this child didn't do very well with the therapy and all, which was explained to the parents earlier, because the other option was only an auditory brainstem implant. But this child requires a lot of training and is using total communication, not only a auditory communication. This was another just to show one of the cases when you are doing a bed, there is a chance of people might injure the dura. So to avoid that, as I showed earlier also, you create an island of bone and only expose the dura in the periphery. In this way you can avoid. And if you want to do the tie hole also, you can put a periosteal elevator between the dura and the bone and then drill the hole so that you don't damage, and you can pass the 1-0 proline and use it for anchoring. Yes, sir. This is one of the common complications what many people face, the CSF gusher. There are different ways of handling it. Either you can do a big cochleostomy as you see in the first case. So so that and wait for the head end elevation and make it and wait for the pressure to reduce. Sometimes it may be 15 minutes, 20 minutes and all. So but never use the mannitol, no need to do it. If it is a very high pressure leak, sometimes you may need to do a lumbar puncture and drainage. So because you made a wide cochleostomy, after electrode insertion, there will be sufficient space for putting the connective tissue seal so that it completely stops the leak. Or as you see in the second case, we can use a tissue visor, so through which you can thread your electrode and do the insertion. At the end of your insertion, the visor itself will block it. Or one can have a metal electrode with the stopper at the proximal end. When you insert that electrode also, after complete insertion of all the 12 electrodes sets, so this stopper will plug the cochleostomy or the round window and stop. As you can see here, this was before putting the electrode, and this is after putting the electrode, where you can see it is tightly plugged. But always one must make sure that you completely stop these leaks before you leave the OT. And always use the facial nerve monitor in all cases of cochlear implant surgeries, especially so if you are dealing with any cochlear anomalies. This was a case where bilateral implant was done. As you can see in this scan, right side it is absolutely fine through the king, whereas in the left hand you see the tip has folded over the final electrodes. So this is more common in slim modular electrode from cochlear. So one has to do a very meticulous insertion to avoid this tip fold over. I will show exact method of electrode insertion, and the direction of insertion also is important when you are dealing with round window or when you are dealing with the cochleostomy. These are the ways how you should follow it. And especially this slim modular electrode, when you are doing, you should strictly follow this. It has got a sheath. After pulling the electrode inside the sheath, then first you have to introduce the sheath, and once you have done a complete introduction of the sheath and this stopper stops at the cochleostomy or the round window, then with the left hand you will be holding this sheath, and with the right hand, in case of right hand, in case of left hand you will be holding the sheath in the right hand and using the electrode insertion through the left hand. So then you hold it, and then here in this case right hand you are holding this knob behind the electrode, and then you are going to slowly push it, and you can see how this electrode is following the modulus and getting without any curling. So you have to do the smooth, slow insertions, and once your insertion is complete, hold the electrode, then you have to pull out the sheath. So once the sheath has come out completely, then you can slowly release your forceps from the electrode array so that it stays in place. So this is how one should follow. Nowadays there is a new equipment has come which is known as the nucleus smart nerve system. It is a wireless real-time intraoperative insights it will give. So to deliver assured in surgical outcomes for both professionals and patients. So it will measure the angular insertion in this, and it will also measure the time, how much you are taking for insertion. Are you doing a smooth insertion or are you fluctuating? So you will see any up and down curves on the map also here. This is a tablet which is showing all this. So it is a real-time measurements, and it enables the surgeon to insert the extended length. It will give you how much time you have taken. So in this case, I did one bilateral implantation where I did 90 seconds for first side and almost 65 seconds for the second one. So this helps you, as you can see here. So the insertion has been complete, it is showing. And then in the second one case, it is showing how you will have if you have a tip fold over, the peripheral electrode, it will also give which electrodes have folded over. So here it is saying everything is fine. So like that, it will be easier to check with this. You have it intraoperative. You can also measure if there are any electrodes which are short circuit or open circuit, it will show on the graph. And not only that, you will also be able to measure the electrically evoked stapedius reflex. This was from the case which I did, a bilateral implant. You will see an absolutely smooth insertion in this. It was not going fluctuating more, only it was within the 1 degree, not beyond that. And all the electrodes were good. And if you click on each electrode, it will tell how much kiloohms the impedance is. All the electrodes were between 5 to 7 kiloohms. And when we did the NR neural responses also, we got a very good responses. At each electrode, you can also check how the wave formation is. And ultimately, we also confirmed it again with the X-ray, a bilateral implant which you could show a very nicely placed electrode array in the cochlea. Actually, with this technique, you may not need it, but initially few cases we wanted to check the intraoperative X-ray also. So this was a case where right implantation was done, 1.5-year-old child, and they couldn't get any responses. So as you can see in this scan, post-op scans, So they have just opened the cochlea, it has entered the cochlea and come out of the cochlea. You could see the whole cochlea is empty. There is no electrode. And then it has gone into the crotch area, so between the carotid and the jugular bulb area. So when I opened up, so I had to cut the electrode and remove the receiver stimulator and the ground electrode. Within 1 month already the cortical mastoid had already little bit closed up. I had to open it again and then dissect out all the fibrous tissue surrounding the electrode with a sharp dissection. One should take care that you don't pull out the electrode accidentally in the beginning itself. So we did that. I had to little bit open up the posterior tympanotomy and thin the posterior canal wall much to have a good access and dissect out, then identified the round window. I opened up the round window, checked, confirmed it with the movement of the incus. After that, see now I am pulling out that electrode. You could see multiple kinks in the electrode array. So there are many ways we can use that. Now because the round window I was able to demonstrate, which they had not seen earlier, so I punctured the round window. I did a round window insertion in this case. But before doing the electrode insertion, I am putting a dummy electrode here to make sure that it is going to the cochlea and not passing out. So, and we also checked this on the C-arm picture to make sure that our electrode is within the cochlea. After making sure, then only I opened the new implant and placed it in the bed, and then slowly we removed that dummy electrode and used the new electrode array for insertion. Even this we were able to, straight electrode, we were able to do it nicely till it is complete insertion, and we also checked again at the end with the C-arm picture to make sure that it is nicely sitting. This was a revision implant, which was a difficult case. And as you can see, there are some problems sometimes, like patient came with a not able to wear processor history of injury, hematoma, and there was a displacement of the receiver stimulator. We had to open up the wound, drain it under antibiotic cover, and then reposition the implant, which was done. This is a repositioned implant, and with the reposition also there was no change in the impedances and the neural responses. We got it. So this is where the sometimes infection can cause exposure of the implant like this. It is very difficult to handle this. So initial stages where the patient is paying for the implant, so this the company will not replace the implant, they will not give it free. So patient may have to buy. That is why we try to preserve initially, where we did a relocation of the receiver stimulator and did the periosteal flaps and skin flaps, rotation flaps. It did work for about 8 months, but ultimately came back with a recurrence of infection. We had to explant the device of the electrode array leaving in the cochlea, and reimplantation was done on the same site at a later date after 6 months, because the other ear was not implantable in this case because of an absent cochlear nerve. If you have a normal nerve, we can do the implantation on the other side. So strict asepsis is very important, to better to prevent this complication rather than dealing with it. So in cholesteatoma formation after implanted ear, so that is a possibility. One should take care during a first surgery not to damage the posterior canal wall and create, or the annulus area through which the external canal squamous epithelium can go in and form a cholesteatoma later. So in these cases, here again, because the patient is paying for the implant, company is not replacing. If it is an early small pocket, if you try to preserve from inside out mastodectomy and canal wall reconstruction, preserve the electrode if it is possible. Otherwise, you do a complete eradication of the disease and do the implantation on the other side. Or sometimes a subtotal petrosectomy with explantation of the earlier device and reimplantation with a new device and blind sac closure also can be done. So this has to be used very cautiously, either in single stage or double stage. This was another case which had in a second time. I will just want to show the insertion of the electrode in this case. See, after opening everything, so then you see when I am inserting, after putting this, with one hand I am taking out the electrode array, old electrode array, and with the other hand I will be doing insertion immediately to avoid that whatever intracochlear tract is there, not to allow it to collapse. See, with the left hand I am pulling it out. This was a contour advanced electrode. With the right hand, immediately this is the opening, so I am inserting a straight array, electrode array, little thinner array. So this will be able to do it, and it were able to do completely. This was another where the implant had failed. This was after 3 years of use, implant had failed here. The company gave the new implant, so we were able to, we explanted this old implant. and dissected out this receiver stimulator, electrode array. Again, we had to do a little bit of posterior tympanotomy as well as thinning of the posterior canal wall, expose it completely, and then took a new implant, placed it in the bed, and then only I removed this old electrode array. See, after placing the new implant and anchoring it, then dissected out the final adhesions, and then I pulled out the electrode array. Electrode array has come out, and then I'm inserting here a foam electrode with the stopper. So you see there will be sometimes a bleeding, so that is why you would insert it as early as possible. So we were able to do it, and these corks closed the cochleostomy, earlier cochleostomy completely at the end of the insertion. And we did get a good neural responses. And of course the tissue was, because here the cork was there, that itself sealed the cochleostomy also. So surgical tips for reimplantation: always use bipolar cautery. So electrode array should be pulled out in surrounding in the last moment, and just 2 slides. A new electrode array should be smaller in size and diameter. So in case of device failures, intracochlear part of the electrode array is left, and use the same intracochlear tract for reimplantation, whereas extracochlear electrodes identify the round window, try to use the round window or extended round window approach. In these cases, always use a dummy electrode first in case of wrong passages. So before confirm it and then only open the new implant. Remember that improper technique and incomplete insertion can lead to traumatic electrode insertions. This is the last video of half a minute. This is how the intraoperative electric stapedius reflex is being. See, for the link sounds, you can see the stapedius reflex here. And even not only that, we did it for the music also. Can you increase the sound? See, with the music also listening, the stapedius muscle is contracting. So this is how the child will respond when the first time the electrode is switched on. This is not the actual response, but next we will get the response. You can see. Please observe his eyes and the facial expression. Now. Nice. This is the first time the child will be hearing the sound after the switch on. So this on switch on and mapping programs, I will not go into much details, everything. And these are the areas which will take care, like audition, language, speech, cognition, pragmatics during the auditory verbal therapy, and setting the goals for that. And this was a child implanted, just listen to her. We'll see for 4, 5. Can you give the...
Yes. Yes. She said, wow. Oh my God, I'm scared. Let's see.
She is the iron hot?
That was at 14 months. This was at 1.5 years.
Hello, my name is Amity. I'm 5 years old. I study KG1A.
And just listen to what the mother has to
I
say.
am Rashmi Anand, mother of Amishi Anand. My daughter was implanted when she was just 13 months old. So my message to parents here is early detection, intervention, helps the child achieve all milestones and help the child.
So in summary, I would like to say in all cases of CSF gushes, one must completely stop the leak before leaving the operation theatre. And intraoperative facial nerve monitoring in CI surgery is mandatory. And intraoperative radiology in all cases of cochlear implantation is useful, especially to detect electrode kinking, tip fold over or other extracochlear electrode placements. Subtotal petrosectomy combined with cochlear implantation is the procedure required in specific situations. One has to choose this carefully. And reimplantation is safe and it is an effective procedure and it should be considered as and when required. So thank you very much with a small note of this child.
I am Tanmaro MP from Bangalore. I am here to tell you my journey from a baby who could not hear or talk anything to the most talkative student in a class. Yes, I am studying in class 8 in a normal school and I love talking a lot. As you can see, I was implanted with cochlear when I was age 2 My mother took me to speech therapy classes regularly, which helped me to improve my speech and hearing skills. I never faced any challenges in understanding my teachers and friends in my school.
Thank you very much for your patience.
Thanks.
Thank you so much, sir. It was such a delight to see such happy faces after cochlear restoration. Now, in order to felicitate Dr. Shankar Medikari, sir, I would like to invite Dr. Vishal Munjal and Dr. Shailendra Ori. Now, I would like to invite Dr. S.K. Jethalia, sir, to felicitate Dr. Shailendra Ori. I request Dr. Vikram Khanna to felicitate Dr. Vishal Munjal. Now it's a great pleasure to again invite on stage Dr. T.N. Janki Ram for the C technique mastoidectomy and otitis and OME. We are taking all the lectures by Dr. Janki Ram as he has to rush back due to some emergency. And for chairing this session, I would like to invite Dr. Sujit Kumar Jethalia, Dr. Yashwant Maru, and Dr. S.K. Pippal. So please come on the stage.
Can we start? So first of all, I thank Professor Sudhakar ji for giving me the opportunity again to present both the talks. I'm giving two talks simultaneously, and also Dr. Sanjay Agarwal ji for this honor. So I'm going to talk about two new techniques. Two new techniques we have sent for publication, not yet published, but two new techniques. But these techniques I've been doing for the past around 25 years. So I should not say in my experience, unless I publish, I should not say that. So I request you to see this technique called C technique. So many people will be thinking, what is there to innovate? Already otology is saturated. No. Every topic you can do something new. So both the topics which I am presenting are my own innovations. Now start. Now we are from Royal Pearl Hospital introducing cholesteatomas. You know, cholesteatomas are benign, expansive aggregation of keratinized squamous debris. Now we have limited cholesteatoma and extensive cholesteatoma. Extensive cholesteatomas are those which involve the erosion of, they erode the ossicles, they go till the mastoid tip, involves the sinus plate, dural plate, all that is seen nowadays in a CT scan. So we always take a CT scan before we do a cholesteatoma. How many of you take, only the juniors, how many of you take CT scans? Please put your hand. Deepak, you're taking, okay. So CT scans are the gold standard investigation. Now, first you are seeing the scan. Okay, you are reading the scan. Scan shows erosion of ossicle. Mostly the incus long process eroded, stapes eroded sometimes, and you are seeing cholesteatoma going till the tip. How will you proceed? Usually what is being taught to us? The outside-in technique. Means you do a cortical mastectomy, you create a facial, there will be a posterior canal wall. You have to reduce the posterior canal wall. Of course, you can't do an intact canal wall for a extensive cholestoma. You reduce the facial bridge, you have to remove the facial ridge. All that is conventional teaching for you. But what I have been doing since 2000, which I have not published so far, because I was concentrating on rhinology, more of rhinology. Now only mostly the first talk I'm giving on otology in any conference actually. So I devised a technique where, see, what is the usual time taken for this? Usual time taken for an MRM is around 1.5 hours. Wait, don't. 1.5 hours it take. Believe me, if you take the C technique and do it, you can do it in 15 minutes. My skin to skin modified radical mastectomy, you can ask my residents, is 10 minutes. Just 10 minutes we finish it. So, canal wall down procedure, Pulwani is there, Deepak, he has seen me. 10 minutes to 12 minutes, I will come out. We can do 15-20 mastoids within a matter of around 2 to 3 hours, which you will be doing one mastoid. So, what is the secret? Now, in a case of an attic cholestoma, modified Bondi's technique is followed. What is modified Bondi's technique? You have a cholestoma here. So, we start drilling from the attic. We just have to follow this cholestoma and go till the end of the cholestoma. That's what the endoscopic surgeons are also doing now. And they stop short and then they excentrate. I am not at all talking about this scenario. I am talking about extensive cholestoma, not for small cholestoma involving attic, so I have a totally different concept about that. So, I am showing a cholestoma where it is going till the sinus plate, dural plate, then till the tip cells. What will you do? My take is, do not do outside-in technique. It is a very cumbersome technique. So, what do we do? Start, right? So, what is the C technique? Now, this is my paper which I have sent. Of course, I underplayed it because we've done lakhs and lakhs of mastoid, but I just sent to JLO saying that 360 patients only we have seen. All patients have been done HRCT and average follows around 8.6 years is my follow-up. Just for publication, I sent it. Next slide. Now, what is the difference between the modified Bondi and the C technique? In modified Bondi is done for minimal disease. This is done for extensive disease. Where does the drilling start in modified Bondi? It starts from the attic. You have to start from the attic. Just lateral to the malleus head or like that, or the incus you have to start. Whereas in my technique, the C technique, it starts from the Henle spine. It starts from the Henle spine. So today I showed you, but I didn't show it properly because it was a very forward-lying sinus, so I was not very happy about it. So there is in this modified Bondi, what I commonly see is you leave behind a very high facial ridge. So there's a incidence of residual in the sinus tympani, or you might have a sump effect. It's called a sump effect, where the drainage will not be proper. There will be a high facial ridge. Whereas in C technique, you will never have that problem. Never have that problem. And the steep learning curve is there for modified Bondi. Why? You are straight away starting from the place where the second genome or the facial nerve is. So if you want to start that, you should be very, very experienced in temporal bone. Whereas in C technique, you don't have any experience, no learning curve. You have to do 5 dry bones and then you will do it. See, yesterday, Dr. Deepak has done one case, he told me. Fantastic, easy technique, sir. So, there is no learning curve, short duration, maximum 15 minutes you will take. Now, let us see the technique. Step-by-step instruction. This is an instructional course. Now, this is the mastoid. Which ear is it? Right ear. Okay. Right ear, this is right ear. You go, see here. You start, this is the Henle spine. This is the annulus. This is the tympanic annulus. You leave behind 5 millimeters lateral to annulus. Something like corner's flap you are taking, no. Like that you leave. See, for example, you have to take off this posterior canal wall skin. Always you take off the posterior canal wall skin and you leave behind 5 millimeters of the annulus. 5 or even 6 millimeters you leave. Now you start from the first step, you start from the 12 o'clock position to the 6 o'clock position. Step 1, start drilling from the 12 o'clock to the 6 o'clock position. C. This is C. C. Next slide. Now,
you just have to keep enlarging the C. Keep enlarging C. At that point, just 5 millimeters lateral, this is the facial. Just posterior to it, you will automatically find the antrum. It's an extensive cholestoma. So you will find the antrum. 100% you will find the antrum. If you have not found the antrum, you have not done the proper indication. Sorry to tell you. Because I am talking about extensive cholestoma. So you will find the antrum here. Now once you find the antrum, see here now, very careful. Now this is the antrum. Don't go and start using your cotton ball or some cup forceps and plucking the cholestoma. Don't do that. Again I say, finish your exposure before you touch your cholestoma. Why? Cholestoma forms a nice barrier for your vital structures. The medial wall of cholestoma is a fantastic protection for the temporal, for the facial nerve or lateral semicircular canal, everything. So now I am finding the antrum here. From here I start. This is what clock? Anti-clockwise direction. This is anti-clockwise direction. So I start drilling the dural plate. So I go along the dural plate. So first is C, enter antrum, dural plate. Next slide. Now I go towards the sinus plate. So it's a sinodural angle, anti-clockwise, go towards the sinus plate. And then go towards the tip. Next slide. And then you see, you go towards the tip, and then you find, if you want, you can find the digastric. If you want, mostly you don't have to, because you don't have to go so deep. But you can actually find the level of the facial nerve, which is corresponding to the lateral semicircular canal here, and start reducing the, already you have reduced most of the facial ridge by the C. By the 6 millimeter only now. 6 millimeter lateral to the annulus only. Have you seen in any case, adults, where facial nerve goes lateral to the annulus? Please tell me, please tell me. You are all big otologists here. It will, in my opinion, I have not seen, I have done, I cannot say the number, lakhs and lakhs, because we do 4,000 mastoids in 1 year. So you can see here, it will never go. Only maybe congenital abnormality, like that you can have, it will go lateral. Annulus is a fantastic landmark. And you have left only 4 millimeters of the annulus here, 4 or 5 millimeters. Already reduced the facial ridge. Then you use the diamond bar and start going. Now next slide. Go here, you start reducing the facial ridge. Okay, here the problem for all the youngsters, what is the problem? To hit the facial nerve. Okay, where they hit usually at the level of the second genu. Second genu only they will hit, no. Avoid the second genu. Go in front. The incus is here. Remove it at the level of the body of incus. Here you remove the bridge. Remove. See, what is the bridge? Definition of bridge is? Bridge is one which bridges the anterior buttress with the posterior buttress. So this is the posterior buttress. This is the anterior buttress. Remove the bridge at the level of the body of incus. Next slide. So here, see, it's all anti-clockwise in the right ear, clockwise in the left ear. Then once you remove the bridge, you go along the tegmen. This is what? Tegmen tympani. This is tegmen alteri. And here, what is this bone? What is the name of the bone? This is scutum. Scutum is down-hanging portion of the squamous temporal bone. It is divided into two. Here is the scutum, here is the cog. Anterior to the head of malleus, you have the cog. So you can drill it nicely till the level of the anterior most part, which is the canal of huge ear. Here, next slide. So once you do that, I am going to show. This is the end of the surgery. And you have to do a sinus tympani drilling. I will show you that. So this is the cholestoma, extensive cholestoma. Next slide. Now I'll show you the, see that C technique. Now just 15 minutes only. See, I start. Which ear is this? Left ear. So one. See the sweep. Everything single sweep. Not like this. Not like this. Single sweep. Single sweep. Single sweep. Just keep going back. Don't worry. You will not hit the facial nerve here. See, use a conical burr. All of you buy a conical burr. You do the, see, already ridge is reduced, almost reduced here. Only 5 millimeters of the ridge is there. Now you are concentrating on going towards the antrum. See, I am going towards the antrum. See, I am going superior and lateral. And I will surely find the antrum there. See that. Here, see, I have already found the antrum. And it is filled with cholestoma. Already the ridge is reduced. 1.5 minutes. Not even 1.5 minutes. It's a real-time video. You see that. Unedited video itself plays only for 8 minutes for me. Now you see here, this is the antrum there. I found the antrum. If filled with cholestoma, you can see it's cholestoma. Then go along the dural plate. You see, go along the dural plate. See, I am delineating the dural plate. Can you see or not, all of you? Yes, Dr. Deepak? Now you go along the sinodural angle and then go along the sinus plate. Such a simple procedure. Nothing, no ado at all. So nothing like, complicated and things like that. So now that's the sinodural angle. Now this is the sinus plate. This is the classical canal wall down procedure. Okay, you have committed on a canal wall down procedure. That I have to say. If you want to have a canal wall intact, you should not do this. You can obliterate the cavity. You can obliterate, you can do whatever later. But this is to do the canal wall down. You see, I have not touched the cholestoma at all. I am just drilling. I have come till the dural plate. I am going down till the level of the tip. Okay, see the cavity. See. Clear. Now I am using only the cutting burr, not even diamond burr. You can beautifully reduce it because at the level of the lateral canal only you will find, see, that's the tip. Very nicely you can drill it nicely and then you reduce then you go from here, I am taking off the facial bridge. With the cutting burr itself we can take off. Why cutting burr? Why? Because already the ossicle is eroded. If I use any burr touching the ossicle, if it is intact, yes and loss. You should not use it. So that is why, now you see, I have removed the bridge. I am reducing the ridge. Everything done with the cutting burr. I am not at all bothered about the cholestoma. I am not bothered about cholestoma. So see here, this is the scutum, drilling of the scutum. I am going up. Single burr, boss. No hangama, no 10 burrs, 20 burrs, nothing. Use the big burr. If you want initially for the facial ridge alone, you can use the diamond burr. Now that is the incus. I am removing. I am not able to see properly. Wait, let me wear. So see the cholestoma. See, many people use different techniques. I use the principle of traction, counter traction. See, traction. See, I am using a hockey. The suction is only pulling it. This is just elevating the cholestoma. That's all. This is the principle of traction by the suction tip and counter traction by the hockey. So that's it. Finish. Once you remove it, the cholestoma will come nicely and then I am going to reduce the ridge. Ridge can be reduced till the level of the facial nerve. If you are really confident, and more importantly, you have to do a canalplasty in the hypotympanum. Very, very important. Once you do that, see, that's the malleus head, and you can see how that is the sinus tympanic. This is the stapes head. You can see the stapes, that's the pyramidal tendon, the stapes head. See, you should always try to address the posterior tympanic sinus and also the sinus tympanic. And now that is a cog which is being drilled. That's a cog which is being drilled, and you can see that we have removed it completely. So basically, you see how simple this mastectomy has become. So try it on a dry temporal bone. 10 dry temporal bones you do C technique. And all of you tell me how it is. Amit, you have to try and tell me. Okay, do dry temporal bones 10. Do this. I am telling you that's a sinus tympani. Finally you drill it. That's called the diving technique. That's also been published. Anyway, so that's the end. So basically that's the... So reconstruction I am not going to discuss now. I just want to... So what I am doing here is to create a small groove here and do what is called the cartilage. Professor Sanjay Agarwal has left. He was with Professor Helms, and you see this is the cartilage palisade. So you create a middle space and you keep that boomerang. It's a cartilage boomerang. Finish. The patient has got very good hearing. 15 minutes, patient over. I'd always do it under local anesthesia. No general anesthesia. See the healing, boss. There is no ridge, nothing. This is how I want you to do a canal wall down procedure. That's the end of my first talk. Thank you very much. So this will be published. After that, I feel that the world will change. I'm very sure I'll start shouting about it too much, like how I shouted about JNA. And then only, see, it is not only enough that you publish, you should shout about that publication. Like Amin Kasam keeps shouting about, see, he's using Johnson buds to elevate the diaphragma and calls it the Q-tip technique. of Kasam. Just for Johnson, but he has published and he's shouting, Q-tip. Now everybody is saying Q-tip technique of Kasam. So that is how Haddad, you know how Haddad found out the Haddad flap? 10 cases, he created CSF leak in FES. If he does FES, definitely CSF leak. What to do? What to do? He is my very close friend, he only told. I didn't know what to do. Suddenly one day I put a septal flap, then I start studying. That is named as Haddad flap. So please understand, if you shout what you have published, you will be remembered. Every day morning I have to talk about Haddad only. I will phone up, what boss, I have to talk about you every day. This is, okay, next presentation please. So this is another important topic. Again, this is my own innovation. And this is going to be published in JLO again. We have sent it. I have to go. My mother is having cancer and I have to be with her. She's got fever now. I have to hurry. That's why I thought I'll leave. Yes, sir, yes. Okay. Now, the diabetic patient comes to you. One diabetic patient comes to you. Diabetic patient presents to you with ear discharge and severe pain. Ear pain. इतना बहुत दर्द है सर, बहुत दर्द है. दर्द है. एक ear discharge में don't diagnose CSOM, boss. Please don't diagnose CSOM. Please. Pain, severe headache. Don't diagnose chronic sinusitis, boss. These are all basic things, boss. Chronic sinusitis will not be diagnosed by severe headache. Headache is not at all a criteria for chronic. That means acute on chronic. It is not chronic. Same way, if you have severe pain, it is either external otitis or acute otitis or complication of CSOM. You cannot diagnose CSOM for severe pain. Please understand that cholestoma never produces severe pain unless it produces complication. Basic fact. Unless it affects the dura, it will not produce. Unless you have an abscess, it will not produce. So if a diabetic patient presents just with a small granulation but severe pain, first you should diagnose malignant otitis externa. So you just put your diagnosis, pen your diagnosis malignant otitis externa. Now, when a patient presents to you with malignant otitis externa, you have made a diagnosis. This patient has severe pain, patient is diabetic, you ask diabetic, take a swab, send it for culture. Start the patient on IV antibiotics. Don't start the patient tablet, amoxicillin, don't do all that. Start the patient straight away on IV antibiotics. Usual antibiotic which we give is piperacillin tazobactam. And IV, you have to give IV, not IM, IV. You have to give IV for 6 weeks. You should give continuously for 6 weeks. Patient will say, what sir, just for pain you give. Believe me, if you give tablet, amoxicillin or ciprofloxacin, something like that, patient will come back with aggravated pain. So now I am telling you, give IV antibiotics, meropenem or piperacillin tazobactam. Culture sensitivity usually will be Pseudomonas, Klebsiella or fungus. Usually fungus is aspergillosis. These are the 3 organisms for, okay, now you are given antibiotics 6 weeks. Patient not all right. Patient having severe pain. Most of the patients, 99% of the patients will be all right. If you diagnose malignant otitis externa and give IV antibiotic, most of the patients will be all right. But that 1% of the patient where you are given tablet, you are given some ear drops, treated as CSOM, this patient is going to come back to you with persisting pain. What will you do for this case? You have to take not a CT scan, you have to take an MRI. Please understand, if you take a CT scan, you will 100% see mastocytitis and you are going to operate on this patient a mastectomy. This is how most of the patients nowadays land up. This is my second lecture, sorry. Now, most of the patients land up like that. Please don't take CT scan, take an MRI. What do you see in an MRI? What MRI do you take? You take MRI T1 with contrast. T1 with contrast or a PET scan with a screening MRI. You have to take this. No other way to diagnose a skull-base osteomyelitis. So either you straight away take a gallium scan, a PET scan. So we do PET scans very often now. 10% we do PET because of the cost. But if you are living in a very nice city like Bombay, Kaushalji or President in Bangalore, you can definitely, after the patient will afford a PET scan, go in for a PET, but at least an MRI is a must. Don't take a CT scan. T1 with contrast, T2 Fiesta. Please write it down. T1 with contrast and T2 fiesta or a cis protocol you should take. And after that, now you look for, number one, what are all the things you have to look for the MRI scan? Number one, look for obliteration of fat planes. Where do you look for it? In the parapharyngeal space and in the infratemporal fossa. Hyperintensity of the dura and the carotid. All these will be there. Classically, it will be there. Soft tissue involvement and cellulitis. Access, you will have parotid, huge parotid swelling. And you might have facial palsy. You can have isointensity in muscular layer, bone marrow involvement. Look for thrombosis of the internal carotid artery. Clearly, in a contrast, you will find a nice abscess. Very nice abscess. Abscess, how much antibiotic you can give? I have seen patients, 6 months, 1 year they have given antibiotic, boss. 6 months antibiotic दिया है IV को. कैसे respond करेगा? ज़रूर नहीं. So 164 patients we have dealt with now in 10 years time. This is our first presentation. This is the first time I am presenting this before my publication, but I am sure that it will be published. All our patients are diabetes with poor 10.5, 10.6 like that HbA1c. Now, preoperative diagnosis was made by MRI and PET scan, HRCT for screening. All our patients were treated with antibiotic course for 6 weeks. Okay, next slide. Now, this is my, what to say, again like JNA, how I found out. This is how I found out in skull-base osteomyelitis. Today I showed you in the dissection also. So this is the right temporal bone. This is the sigmoid sinus, facial nerve, and this is the carotid artery. This is the horizontal carotid, this is the vertical. All of you saw in the dissection. How many didn't see? Oh, you didn't see. Then you didn't attend the dissection. You've seen. Okay. Now you saw the vertical carotid and you saw the horizontal carotid. Now you see this is how we are going to present it. Now, next slide. My classification. This is class 1. I told you this is the commonest site. Commonest site is anterior to the carotid, infratemporal fossa. So, don't see in the mastoid. Don't see where it is in the mastoid. You will not find anything, or you will find some mastoiditis and you will do mastoidectomy and come out. Subtotal petrosectomy is not at all the surgery of choice for skull-base osteomyelitis. It's only the starting point of the surgery. And never do a blind sac closure. Many people nowadays are doing blind sac closure. They are actually playing with this disease. Now I am seeing also Baha being done. Cochlear implant being done. You know, everything is being done now. So don't do all that. This is the first area you should see in the MRI scan. Anterior to the carotid. Next slide. This is class 1 disease. Class 2 disease, you see, this is where it will affect. In the stylomastoid foramen. This is the class 2. Here the facial nerve, some patients can present with facial nerve palsy, some patients can present with 9, 10, 11 palsy. So what we do, we remove this and do a Ishiki also. Same sitting we do Ishiki. And patient regains his voice. Next slide, this is class 2. Class 3, today I showed you infratemporal fossa type B. This is where it affects. Subtemporal dura. This is middle meningeal artery V3. So this is class 3. Class 4, next slide. This is around the carotid. I showed you transposition of the carotid today. This is how it affects here. So you should be able to deal. So this is completely epicentered around the carotid. Why it has to affect the carotid? Why? Because the actual infection starts at the junction of the bony and cartilaginous junction. Correct, no? You are seeing granulation at the floor, bony cartilage junction. From there through all the foramina, Pushka, Sanctorini, everything it will go. What is anterior to it? Anterior to it is the carotid. So immediately, this is the easy spread for it. It will go around the carotid. What is next anterior? Infratemporal fossa. That is how it affects. Or if it goes down, it will affect the stylomastoid foramen. See how logical it is. If it goes above, it will affect the dura. If it goes around the carotid. So carotid is anterior. Posteriorly, why doesn't it spread? Why doesn't it spread posteriorly? Because the facial nerve sheath is there. Nicely, the sheath, the periosteum, all that is a barrier for this pus to penetrate. So here we got, next slide. Now, see, it can go to the clivus. It can go to the clivus or nasopharynx. I showed you today in the dissection. Next slide. So I'm going to show you some case scenarios. 5 minutes I'll show you. Class 1 skull base disease. See here. Now this is a live patient. Of course, Professor Sudhakar ji has seen many lives, 17, 18 lives you have done. You can see here, this is the left ear. I'm now drilling little, yeah. Now this is the carotid artery. This is the carotid artery here. Now we are drilling the subtemporal dura. Now you see, I am now using the bipolar. See the bipolar. I am using the bipolar and this is all necrotic tissue. See the, can you see the carotid here? My dear friends, see the carotid. Anterior to the carotid is the disease. If you drill till here, there is no use. That is the disease there. So I am going to show you now. கொஞ்சம் fast forward. Just forward. Yeah. Forward. So now you see here what I am doing now. I am now going to go towards the infratemporal fossa. See, that's the parotid. I showed you the temporomandibular joint, and then I am going anterior to the carotid. You will have sequestrum, you will have bone, you will have a lot of see what happens. See the pus. Can you see the necrotic tissue? See that? See that? Can you see? How the antibiotic is going to penetrate in this pus? 100% it will not. See the sequestrum also. So when you have sequestrum, see the pus is pouring like this. And if you have pus, how can you do blind sac closure? You should not do blind sac closure. Now, next slide. Now, I'm just going to go forward. See, that's the sequestrum. Case 2, skull base osteomyelitis. See now, this patient, please understand, when you do mastoidectomy, you will not find anything. It will be normal. You will think, your normal case, we have done mastoidectomy. No. You see here what happens. You have gone to the mastoid tip. See what is happening now. See, that is, see. See the pus, class 2 disease. So unless you make it out in the MRI, you cannot deal with this. This is class 2 disease. See how much of pus is coming out. Can this patient be all right of pain if you give tons of antibiotics? No chance. Now we will decompress this facial now. Next slide. I just want to show them the scenario and go. Class 3. See this case. Now this is along the subtemporal dura. This is the left ear. Just forward it a little bit. Forward. Very interesting case, this one. Now, Now this is the carotid artery. Stop. This is the carotid artery. See what I am doing here. The sequestrum is sitting right on the carotid artery. See what I will do now. See, this is all along the subtemporal dura. Okay, see here. This is the bipolar. Use a non-stick bipolar. In all cases, use a non-stick bipolar. See, that's the carotid artery. So that's the dura. This is along the dura. Today morning we showed in the dissection. Pus was sitting along the GSPN. Along the GSPN you will find pus. Only thing is, don't open the dura. Dura is a nice barrier. You should not open the dura. Now you see, I am now taking all the tissue along the subtemporal dura. Konja forward paniko. Just a little forward, please. This is all sequestrum bone over the carotid artery. Now I am going to drill the carotid. Anterior to the carotid. Forward. So you can see here that it is basically along the carotid that this disease. See. Now I am taking that bone over the carotid. See. Sequestrum. I am uncapping the carotid. Like what we did in the cadaver. See. Imagine you do a small wrong movement, patient will die on the table. But if you don't do this, patient will not be all right. It's a two-edged weapon here actually. See, we are removing all the sequestrum bone from the carotid artery. It's all carotid artery. Next slide. Now let us just show them. Yeah. Okay, now class 5. See here. Now this patient has got a abscess which has gone to the clivus. From the ear gone to the clivus. Today I showed you. I am doing an endoscopic modified Denker slide. Forward pannu. Just see that I'm doing a Denker's. In, I think, how many patients will show? We do the nose and the ear simultaneously. What we did today, nose and ear simultaneously we do. See what I'm doing. I'm taking off the longest capitis muscle. See, now I can find pus in the, see the pus came out. See, can you see? See, from the clivus the pus is coming out. How will the patient be all right? You do the ear, how will the patient will be all right? You have pus in the clivus. It will not penetrate. Antibiotic will not penetrate. See, I am drilling the clivus now, full of. So we have to do a complete clivectomy. Along with the ear, you have to do clivectomy. Next slide. Just. Yeah. So this, and nasopharyngectomy also. So conclusion. Malignant arteries externa is becoming very rampant in India because this is the diabetic capital of the world. China and India have the highest number of diabetics. I am a diabetic. Every fourth person is a diabetic. For a 1.3 billion population, imagine how many diabetics we have. And for every 10th diabetic, you have a diabetic ear. That means, you see the number of cases we are going to face in future. The youngsters are going to face only this, more than cholesteatoma. So, if you have a disease, you have to need to identify and give antibiotics IV for 6 weeks. You are the young generation, you should do it. Next slide. Skull-based osteomyelitis is not malignant arteries externa. It's a complication of malignant arteries externa. If you don't treat it properly, then you have to do an MRI, is the investigation of choice. Next slide. Now, surgical protocols have been devised according to the site involved. We will just publish and we'll let you know. We propose a staging system. I told you class 1 to class 5. Surgery when done the right indication. You will not believe, next day, the patient will fall in your feet. Believe me. He will fall and say, you are God. This is what we are experiencing. Sir, इधर उधर गया कुछ भी फर्क नहीं पड़ा मैं तो suicide, they'll say I want to commit suicide. Next day they'll get up and say, sir, I am a new man. I couldn't believe all this when I started, but now I have started believing this is what is going to be the future, and that is why I am presenting this for the youngsters before even I am publishing it. Don't miss this disease. Okay, so get trained in your temple bones like this so that you can operate on this case. Thank you very much, Professor Sudhakar ji, Professor Kaushal ji, Professor, and also the chairpersons.
Thank you very much, Dr. Janki Ram sir. You have a very illustrative and informative presentation. I think the youngsters must be listening. This thing have visualized the very nice techniques, especially the C type of techniques. New people will try to follow it. Of course, it is require a practice on cadaver as he suggested. So it is really nice. So I will also try. I am little elder, but I may try this thing. Thank you very much.
Thank you, sir. Thank you.
Thank you so much, sir. Now, as sir has already told that he needs to leave, so we'll be moving towards the felicitation and honoring our respected guest faculty and chief guest for this AI Con. So I would like to invite Dr. Kaushal Seth, Dr. Shankar Medikari, and Dr. Sudhakar Vaidya to please come on the stage and honor Dr. T.N. Janki Ram. And along with, I would like to invite all our chairpersons on the stage as well. A big round of applause, please. In order to felicitate all our chairpersons, I would like to invite Dr. P.N. Verma on the stage to felicitate Dr. S.K. Jethalia. I would request Dr. B.S. Chauhan to please felicitate Dr. Y.K. Maru. And I would invite Dr. Sudhakar Ogle, sir, to please felicitate Dr. S.K. Pippal. Thank you so much, sir. Now we are moving towards our inauguration ceremony. So in a few minutes, we'll be starting the inaugural event. So I would request you all to be present here for the inauguration ceremony.